Nghệ Bệnh viện Đại học Y Dược xuyên mắt.
We would like to begin the round with the cultural performance, rich in Vietnamese identity, titles The Shower of the Rin Sea, represented
Bệnh
by
viện
the
Đại học Y
team
Dược
from
xuyên mắt.
Singmar University Hospital. Round with the cultural performance, rich in Vietnamese identity, titles The Shower of the Rin Sea, represented by the team from Singmar University Hospital. Round with the cultural performance.
Thuở bé cũng đã từng ước sau này mình lớn sẽ trông ra làm sao, sống thế nào. Rồi ngày xưa cũng đã từng ước sau này mình lớn sẽ đi một nơi khắp phương trời. Rồi cuộc đời đã đưa tôi đi rất xa, người ước mơ giờ đã chấp cánh người xa bước mơ. Và tôi gieo mầm xanh ấy cho cuộc đời, nhẹ vươn tay và tiêu tưới lên cao vời. Đến một ngày tương lai rồi mầm xanh kia sẽ tỏa bóng râm chở che các con đường. Ai sẽ cùng bước qua cuộc đời, để lại những hành trang ở đây thế giới sẽ thật đẹp nếu như một ngày ta mình cười buông tay ở dưới tán cây mình gầy.
Chào mừng quý vị đại biểu, quý vị quý cùng toàn thể quý anh chị đồng nghiệp tham dự hội thảo khoa học, kỹ thuật hình ảnh y học và kỹ thuật xạ trị 2025 do Chi hội Kỹ thuật Điện quang và Y học hạt nhân Việt Nam, Hội Kỹ thuật Hình ảnh y học Thành phố Hồ Chí Minh, Chi hội Kỹ thuật xạ trị Thành phố Hồ Chí Minh, Hội Kỹ thuật Điện quang Thế giới và Bệnh viện Đại học Y Dược CIMAC tổ chức. Đồng thời được phát trực tuyến trên các kênh truyền thông YouTube của Chi hội Kỹ thuật Điện quang Y học hạt nhân Việt Nam.
Good morning, ladies and gentlemen. Welcome all of you to the Isrrt-Rt, RTT Workshop 2025, Medical Imaging and Real Therapy Techniques, organized by Vietnam and Ho Chi Minh City Associations of Radiological Technologies, collaboration with International Society of Radiographer and Radiological Technologies, ISRRT, and University Medical Singapore Hospital, Đồng Nai Province, and also podcast live on the media channel YouTube of Vietnam Association of Radiological and Technologies VART.
Hội thảo với chủ đề chuẩn hóa kỹ thuật hình ảnh y học và xạ trị từ tiêu chuẩn quốc tế đến trí tuệ nhân tạo.
Come to this conference with the theme Standardization of medical imaging and radiotherapy from international standard to AI.
Đến dự hội thảo ngày hôm nay, xin trân trọng giới thiệu Thạc sĩ Thái Văn Lộc, Chủ tịch Chi hội Kỹ thuật Điện quang Y học hạt nhân Việt Nam, Chủ tịch Hội Kỹ thuật Hình ảnh Y học Thành phố Hồ Chí Minh.
Mr. Thái Văn Lộc, resident of Ho Chi Minh City, Association of Radiological Technologists.
Thạc sĩ Phan Đức Tính, Chủ tịch Chi hội Kỹ thuật xạ trị Thành phố Hồ Chí Minh.
Mr. Phan Đức Tính, Radiotherapy Managers at the Hospital.
Thạc sĩ Nguyễn Tấn Dũng, Phó Chủ tịch kiêm Tổng thư ký Chi hội Kỹ thuật Điện quang và Y học hạt nhân Việt Nam.
Mr. Nguyễn Tuấn Dũng, Vice President of Vice General of VART.
Tiến sĩ bác sĩ Lê Tuấn Anh, Giám đốc Trung tâm ung bướu trưởng khoa hóa xạ trị Bệnh viện Chợ Rẫy.
Dr. Lê Tuấn Anh, Director of Chợ Rẫy Oncology Center, Head of Radiation and Chemotherapy Department, Chợ Rẫy Hospital.
Tiến sĩ bác sĩ Nguyễn Thị Minh Huệ, Phó khoa hóa xạ trị Bệnh viện Chợ Rẫy.
Dr. Nguyễn Thị Minh Huệ, Deputy Head of Radiochemical Department, Chợ Rẫy Hospital.
Tiến sĩ bác sĩ chuyên khoa 2 Đặng Vĩnh Hiệp, trưởng bộ môn hình ảnh y học trường Đại học Y khoa Phạm Ngọc Thạch.
Dr. Đặng Vĩnh Hiệp, Head of Medical Imaging Department, Phạm Ngọc Thạch University of Medicine.
Bác sĩ chuyên khoa 2, chuyên khoa 1 Phan Công Chiến, Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh.
Dr. Phan Công Chiến, University Medical Center, Ho Chi Minh City.
Ông Trần Thắng Châu, nguyên kỹ thuật viên xạ trị cao cấp Bệnh viện FV.
Mr. Trần Thắng Châu, former Senior Radiotherapy Technician at FV Hospital.
Bác sĩ chuyên khoa 2 Nguyễn Minh Triết, Phó khoa xạ trị Bệnh viện Ung bướu Cần Thơ.
Dr. Nguyễn Minh Triết, Vice Head of Radiotherapy Department, Cần Thơ Oncology Hospital.
Về phía Bệnh viện Đại học Y Dược Xuyên Mát Đồng Nai, xin trân trọng giới thiệu bác sĩ chuyên khoa 2 Trương Quốc Trương, Giám đốc chuyên môn bệnh viện.
Chief Medical Officer Dr. Trương Quốc Trương.
Bác sĩ chuyên khoa 1 Lương Đình Thứ, trưởng khoa chẩn đoán ảnh và thăm dò chức năng.
Dr. Lương Đình Thứ, Head of the Department of Diagnosis Imaging and Function Exploration.
Thạc sĩ bác sĩ chuyên khoa 2 Trần Trung Kiên, trưởng khoa ung bướu.
Head of Radio Oncology Department, Dr. Trần Trung Kiên, University Medical Smart Hospital.
Về phía các nhà tài trợ, xin trân trọng giới thiệu đại diện công ty VT Healthcare,
Representative of VT Healthcare Company.
đại diện công ty trách nhiệm hữu hạn Bayer Việt Nam,
Representative of Bayer Vietnam Company.
đại diện công ty trách nhiệm hữu hạn Mirarini Việt Nam,
Representative of Minarini Vietnam Company.
đại diện công ty cổ phần đầu tư y tế Việt Nam,
Representative of Vietnam Medical Investment Joint Stock Company.
đại diện công ty trách nhiệm hữu hạn Varian Việt Nam,
Representative of Variant Introduced Medical Symptom.
Đến dự hội thảo ngày hôm nay, về phía khách mời quốc tế, xin trân trọng giới thiệu cô Tang Chi Quy, Phó Chủ tịch Hội Kỹ thuật Điện quang Thế giới.
Mrs. Tang Chi-Quy, Vice President Asian and OJR of Isrrt-Rt.
Giáo sư Trung Quang Hong, Chủ tịch Hội Kỹ thuật Hình ảnh Y học Hàn Quốc.
Professional Chung Quang Hong, President of KRTA Korea.
Tiến sĩ Hồ Quy Duyen, Chủ tịch Hội Kỹ thuật Điện quang Đài Loan.
Dr. Ho Peiyan, President of Taiwan Society of Radiological Technologies. Professional Chi Phong Liu, Taiwan.
Mr. Sohei Mito, Japan.
Mr. Farhez Parameswaran, India.
Mr. Ragan Hong Lung Liu, Hong Kong.
Mr. Ho Yin Yip, Hong Kong.
Mr. Chi Long Yin, Hong Kong.
Mr. Joseph Lee, Hong Kong.
Mr. Rakesh Khan, India.
Mr. Ho Quan Ta, Singapore.
Hàng năm, Hội Kỹ thuật Điện quang Thế giới đều triển khai các chương trình hỗ trợ thiết thực dành cho các quốc gia thành viên. Mục tiêu cốt lõi của các chương trình này là thúc đẩy sự phát triển chuyên môn cho ngành cộng đồng kỹ thuật trong lĩnh vực điện quang, hình ảnh và y học xạ trị.
Enrolling the International Societies of Radiographer and Radiological Technologies (ISRRT) implement critical support program for its member country. Core objective of this project is to foster continuous professional development for the communities of radiographer and radiological technologies in the fields of radiography, medical imaging, and radiation therapy.
Các hình thức hỗ trợ bao gồm việc tổ chức các buổi giảng chuyên sâu do các chuyên gia, học giả đầu ngành trên thế giới trình bày, cung cấp thông tin cập nhật về các phương pháp điều trị, kỹ thuật chẩn đoán tiến bộ, cùng với việc tạo ra cơ hội giao lưu trao đổi kiến thức kinh nghiệm với quốc tế.
The form of support include organizing in-depth lectures delivered by leading expert and scholars from around the world, providing updates on advances, treatment modalities, and diagnosis techniques, along with the creating opportunities for international exchange, knowledge sharing, and experience transfer.
Trong năm nay, Việt Nam vinh dự là quốc gia thành viên được Hội Kỹ thuật Điện quang Thế giới lựa chọn để triển khai chương trình hỗ trợ đào tạo chuyên biệt. Sự kiện này được tổ chức bởi hỗ trợ chuyên môn trực tiếp từ Hội Kỹ thuật Điện quang Thế giới nhằm mục đích nâng cao năng lực, cập nhật kiến thức chuyên sâu cho kỹ thuật viên đang công tác trong lĩnh vực hình ảnh y học và xạ trị trên toàn quốc. Đây cũng chính là lý do của buổi hội thảo ngày hôm nay.
This year, Vietnam has the honor of being the member country selected by the Isrrt to host the dedicated training supports the program. The event is organized with the direct scholarship and professional support of Isrrt, going to enhance the competency and assess the specialist knowledge of technologies currently working in the field of medical imaging and radiation therapy mentioned. This is the main reasons for today's workshop.
Theo chương trình, xin trân trọng kính mời Thạc sĩ Thái Văn Lộc, Chủ tịch Chi hội Kỹ thuật Điện quang và Y học hạt nhân Việt Nam, Chủ tịch Hội Kỹ thuật Hình ảnh Y học Thành phố Hồ Chí Minh phát biểu khai mạc hội thảo.
Next, we respectfully invite come to the stage Mr. Thái Văn Lộc, resident of Vietnam and Ho Chi Minh City Association of Radiological Technologies, have a few words.
Communist Vietnamese, 2 minutes English. Kính thưa các thầy cô, cảm ơn bệnh viện Smart Bắc, Dr. Trương, thầy Trương và đại diện cho bệnh viện Smart và ban giám đốc cũng như các thành viên trong ban tổ chức và phối hợp với hội rất là chu đáo. Tôi chỉ muốn nói lời cảm ơn tất cả các bạn làm việc quá chuyên nghiệp, kể cả tiết mục văn nghệ. Muốn cảm ơn sự ngạc nhiên của tôi là sự có mặt của thầy Tuấn Anh hôm nay có mặt ở đây, và tôi vừa rồi tôi có dự cái hội nghị của chợ rẫy, thì xin lỗi thầy là hôm đó chỉ dự thấy thầy ngồi trên và không có thời gian để nói chuyện và tôi phải đi công tác, cho nên là tí nữa xin gặp thầy để nhờ thầy hỗ trợ tiếp tục cho cái nhất là lĩnh vực radiotherapy của Việt Nam chúng ta. Và tôi cũng xin gửi lời chào đến 200 trên 200 gần 300 người đang online trên tuyến, khoảng gần 300 các bạn đang ngồi đây. Và chúng ta cũng biết là hiện nay có khoảng gần 300 các bạn trên toàn thế giới cũng online. Và tôi nhắc là các bạn nào mà muốn nghe tiếng Việt thì trên Zoom chúng ta có hai cái channel, hai cái kênh, các bạn cứ vào đó nghe tiếng Việt. Và còn các bạn nào nghe được tiếng Anh thì vào tiếng Anh. Còn như chúng tôi đã thông báo, các bạn nào trong hội trường này nghe không được tiếng Việt, xin lỗi, nghe không được tiếng Anh, thì các bạn cứ việc mở quét cái mã QR phía sau cái bảng tên mình đấy, rồi các bạn đưa vào tai, mang cái earphone cá nhân của mình để nghe, và trên này vẫn nhìn ở đây. Như vậy là chúng tôi đã cố gắng, đã làm tốt, mang những thông điệp của thế giới đến với tất cả các bạn. Và tôi cũng muốn cảm ơn thành viên trong ban tổ chức của hội phối hợp rất là chặt chẽ với việc để tổ chức ngày hôm nay. Và tôi ở đây, nhân đây tôi kêu gọi các bạn Gen Z, lần này tôi sử dụng toàn bộ các bạn Gen Z dưới 24-25 tuổi trong công tác dịch và công tác tổ chức. Và tôi hoàn toàn tin tưởng thế hệ AI này, thế hệ digital này, tin tưởng vào thế hệ trẻ Việt Nam. Thế hệ trẻ Việt Nam Tôi hoàn toàn tin tưởng và các bạn cứ yên lòng. Hôm nay ngồi đây, bạn trên online và các bạn ngồi trong khán phòng, nếu mà nghe earphone, bạn nên nhớ rằng âm thầm ở một cái phòng khác, các bạn trẻ, thế hệ Gen Z đang ngồi dịch vụ. Và tôi thấy rằng chúng ta cũng nên khai thác bố mẹ hàng ngày. Đây bao nhiêu năm nhiều rồi, ngoài đi học ở trường, rồi các bạn lại cung cấp sách đến các cái trung tâm ngoại ngữ để học. Thì hôm nay tôi sẽ sử dụng điều đó để mang lại cho người Việt Nam chúng ta bước ra thế giới, và tôi hoàn toàn tin tưởng trong tương lai đất nước chúng ta các bạn sẽ là nền tảng cho đất nước chúng ta cất cánh. Ok, lần nữa tôi cảm ơn, và tôi sẽ nói tiếng Anh để chúng ta vỗ tay một lần. Ok, sorry. Good morning, everyone. Today, audience have more 200 audience. I want to say hi with all audience in the world, from the US, from Australia, from New Zealand, from the Philippines, Myanmar, Sri Lanka, many audience now. They look for you. The first, I thank you, Isrrt first, Executive Vice President Isrrt Asia Australia. I thank you so much. My sister, you work hard. You arrange for many people, many specialists from many country come here. I understand. Thank you so much. I know you very work hard. Thank you so much. ISRD and the country. And also thank you, my friend. You are specialist. We select. I discussed with Checkwe before. We select. Oh, you are come here today. You representative for ISRT, not only for your country, for your society. You representative for ISRT in your hand. Okay, and uh, now my friend come from in Korea, in Japan, good team from Hong Kong, good team from Hong Kong and Singapore, and from India. For example, he uh, 40 years ago experience. It's more than 40 years ago experience radiotherapy. Congratulations and thank you so much. And from Taiwan, Professor Lu and President Taiwan. Okay, President Korea also today. I want to say with all areas audience in the world today. It's today you let's give us many questions. You remember today many own specialists they share experience topic today AI and standard technology standard and AI, and then not only Vietnamese, they give us many questions for speaker today. Okay, and again, last thing, I'm on the way. Stay tense. I believe uh, we always start from in another country, and I believe you continue support for young generation in Vietnam in near future. We push the young generation in yesterday and today. You saw only young generation in Vietnam. Believe that in Vietnam, next time we grow up in AI generation. Thank you. Thank you so much, everyone. Thank you, all friends. Thank you. Thank you, all friends. Thank you.
Xin cảm ơn Thạc sĩ Thái Văn Lộc.
Thank you, Mr. Tagalog, for your speak session.
Hội thảo được tổ chức tại Bệnh viện Đại học Y Dược Xuyên Mắt, là một trong những bệnh viện hiện đại y khoa tại Việt Nam. Vinh dự được đón tiếp đại diện Bệnh viện Đại học Y Dược Xuyên Mắt, trân trọng kính mời giám đốc chuyên môn bác sĩ chuyên khoa 2 Trương Quốc Trương có đôi lời phát biểu.
The workshops were organized by University Medical Shinmark Hospital one of the top model general hospital in Vietnam. I would like to invite Chief Medical Officer Dr. Trương Quốc Dương come to the stage for expressions a few words.
Lời đầu tiên, cho tôi xin kính chào quý vị đại biểu. Thành thật và chia sẻ. Cho tôi xin được cảm ơn anh Thái Văn Lộc đã dẫn dắt và đã đưa tôi có cơ hội để cùng tiếp đón các vị đại biểu, các nhà khoa học, cũng giống như là quý vị khách mời có mặt sáng hôm nay tại Bệnh viện Đại học Y Sinh Mặt. Xin kính cảm ơn.
Today he really he was on the pleasure from his heart, and he say he really happy to see everyone to come to here to the Isrrt Capital University.
Tôi rất vinh dự và vinh hạnh để đại diện cho Bệnh viện Đại học Y Sinh Mắt xin hân hoan đón chào quý vị. Và một lần nữa, trong cảm xúc của buổi hội thảo hôm nay, tôi thành thật cảm ơn và một lần nữa là cảm ơn quý vị rất nhiều.
From his heart, from the border of his heart, he say he really happy, and this is the big opportunity for him to be see everyone to standing in here. So he hope all the people in here enjoy this conference.
Thưa quý vị, để bắt nhịp được với cái sự phát triển của trí tuệ nhân tạo, giống như là cái suy nghĩ của người đứng ra tổ chức, đó là anh Lộc, thì Bệnh viện Đại học Y Sinh Mắt cũng là một cái cầu nối để rồi trong tương lai không xa chúng ta có thể vận dụng được những cái công cụ của cái trí tuệ nhân tạo để vận dụng vào trong cuộc sống.
Follow to the development of the countries. So he want to be using the AI to the normal life of the people, just like using the AI to the medicals. And he say he really thank you, Mr. Thái Văn Lộc, to be do this topic.
Và đặc biệt trong chuyên đề của ngày hôm nay được quý thầy cô ở một số quốc gia trên thế giới nói về hai chuyên đề. Một đó là xạ trị và vấn đề thứ hai đó là điện quang. Một trong hai vấn đề đang hết sức nhức nhối trên toàn cầu hiện nay, đặc biệt là cái tỷ lệ bệnh ung thư ngày càng gia tăng so với một số quốc gia. Đặc biệt ở tại Việt Nam thì cái tỷ lệ ung thư ngày càng có xu hướng tăng hơn và trẻ hóa hơn rất nhiều.
Nowadays we have to measure the radiological and radiographer. So today
Tôi hy vọng rằng trong một ngày tương lai không xa, khi vận dụng cái công cụ của AI vào trong chẩn đoán, vào trong điều trị, một trong những cái mà một ước mơ chẩn đoán nhanh chóng, điều trị có hiệu quả cũng là nhờ các cái chuyên gia, các nhà khoa học hỗ trợ để rồi đó là những người bệnh của chúng ta để giảm những nỗi đau, và những nỗi đau này được phát hiện sớm và hết kịp thời trong quá trình điều trị.
he wants another day the AI will be using more and more in countries. So they want to be using this techniques for to help the patient increase their pains, just like the number of the to cancer and tumor of patient. They really higher nowadays, so they want to be in decrease that.
Hơn thế nữa, bệnh viện Sinh Mắt chúng tôi cũng có những cái phương tiện, đặc biệt là máy variant trong điều trị và một cái đội ngũ nếu có cơ hội để được học, tiếp cận thêm với thế giới, tiếp cận thêm những cái chuyên môn kỹ thuật cao hơn, thì tôi hy vọng rằng ở tại cái tỉnh Đồng Nai và một số các tỉnh thành lân cận với mật độ dân là 6 triệu người sẽ được thụ hưởng một cái thành quả của cái ngày hôm nay.
Nowadays, in the Sigmar Hospital, he have the better machines, and he heard in another day, 6 million people in the Đồng Nai province will be have more diagnosis and treatment better for them.
Một lần nữa cho phép tôi, quỹ thời gian không nhiều, kính chúc quý vị đại biểu, quý vị khách mời cùng các anh chị em xa gần trong nước quốc tế sẽ có một buổi hội thảo chia sẻ kiến thức thành công tốt đẹp. Một lần xin chân thành cảm ơn.
Xin cảm ơn bác sĩ Trương Quốc Trương.
Thank you, Dr. Chung Wook Jung for your speak section.
Và tiếp theo, trân trọng kính mời bà Tăng Trek Quy, Phó Chủ tịch Hội Kỹ thuật Điện quang Thế giới, Bệnh viện Đại học Quốc gia Singapore có đôi lời phát biểu.
Thank you. A very good morning to our distinguished guests, ladies and gentlemen. Xin chào. It is my great pleasure to welcome all of you to the first Isrrt Medical Imaging and Radiation Therapy Workshop on Head and Neck Immobilization. Today marks a significant milestone for Isrrt, as this is the first combined workshop bringing together medical imaging and radiation therapy in Vietnam, together under one collaborative platform. As many of you will know, Isrrt is the only international organization representing both radiographers and radiation therapy worldwide, serving over 500,000 society members. This global reach gave us a powerful voice to support our radiographers and radiation therapists to professional excellence and contribute to a safer and effective healthcare for our patients. I would like to express my sincere thanks to Dr. Chung and the director of Shinmark Hospital for allowing us to host this event at the Shinmark University Hospital. I would also like to thank Mr. Taiwan Lok from the Vietnam Association of Radiotechnological Technologies and his committee members for organizing this event, and also not forgetting our member societies, the Hong Kong Association of Radiation Therapists, the Indian Society of Radiographers and Radiological Technologies, the Japan Association of Radiological Technologies, the Korean Association of Radiological Technologies, and Taiwan Societies of Radiological Technologies for their invaluable support for this workshop. This workshop is a true demonstration of collaboration between Isrrt and our member societies, showing that what is possible when we work together with a common purpose. I'm glad to share that there are over 250 participants joining us here in person and more than 300 participants attending online. Through this workshop, I hope that we will share knowledge, exchange our experiences, and learn from one another, regardless of whether we are working in imaging or radiation therapy. It is important that we are united to improve our treatment accuracy, enhance safety, and ensure that our patients receive the best possible treatment. As we all know, technology continues to evolve and healthcare demands grow. And we need to be more trained in or acknowledge the cross-disciplinary understanding and international cooperations is important more than ever. I hope that this workshop will not only strengthen your clinical insights, but also build new friendships and opportunities for collaboration beyond borders. Once again, thank you all for joining us at this workshop, and I wish everyone a fruitful and fun and enjoyable workshop today. Thank you.
Xin cảm ơn bà Tăng Trek Quy.
Thank you, Mrs. Tong Chakui, for your speak session.
Theo chương trình, xin mời bác sĩ chuyên khoa 2 Trương Quốc Trương, giám đốc chuyên môn, đại diện cho ban lãnh đạo bệnh viện Singmark lên nhận bằng khen danh dự. Mời cô Tăng Trích Quy, Phó Chủ tịch Hội Kỹ thuật Điện quang Thế giới lên trao bằng khen.
I would like to invite Mrs. Tang Chikwi, please come to the stage to present the certificate.
Xin cảm ơn cô Tăng Trích Quy. Xin mời bác sĩ Trương nán lại sân khấu. Xin mời giáo sư Trung Quang Hong, Chủ tịch Hội Kỹ thuật Điện quang Hàn Quốc lên trao giấy chứng nhận.
I would like to invite Professional Tung Quang Hong. Please come on the stage to present the certificate.
Xin mời tiến sĩ bác sĩ Lê Tuấn Anh, giám đốc trung tâm ung bướu Chợ Rẫy, trưởng khoa hóa xạ trị bệnh viện Chợ Rẫy lên sân khấu. Kính mời tiến sĩ Hầu Quỷ Tràng, Chủ tịch Hội Kỹ thuật Điện quang Đài Loan.
I would like to invite Dr. Ho Quei-Chens, Taiwan. Please come to the stage to present the certificate of the hospital.
Xin cảm ơn.
Thank
Tiếp
you.
theo, xin mời ông Trần Thắng Châu, nguyên kỹ thuật viên xạ trị cao cấp bệnh viện FV lên sân khấu. Mời thạc sĩ Thái Văn Lộc, Chủ tịch Chi hội Kỹ thuật Điện quang và Y học hạt nhân Việt Nam lên sân khấu trao tặng giấy chứng nhận.
I would like to invite Thái Văn Lộc come to the stage for present the certificate. Em đọc ạ.
Xin cảm ơn. Về phía nhà tài trợ, xin mời đại diện công ty VT Healthcare lên sân khấu. Mời đại diện công ty Bayer Việt Nam. Mời đại diện công ty Merorini Việt Nam. Mời đại diện công ty cổ phần đầu tư y tế Việt Nam. Và cuối cùng là công ty Varian Việt Nam lên sân khấu.
I would like to invite the representative of VT Healthcare Company, the representative of Bayer Company, representative of Minerini Vietnam Company, and representative of Vietnam Medical Investment Trust Stock Company, and representative of Variant.
Mời thạc sĩ Thái Văn Lộc và thạc sĩ Phan Đức Tính lên trao giấy chứng nhận.
Tôi xin cảm ơn rất nhiều các công ty. Thật ra thì cũng chia sẻ với các bạn trên toàn quốc là rất là cảm động, bởi vì liên tục trong năm vừa rồi quá nhiều hội nghị về kỹ thuật điện quang Việt Nam, cho nên chúng tôi cũng không muốn, lần này chúng tôi cũng muốn thực lòng không muốn làm phiền đến các công ty, mà hoàn toàn các công ty đã gợi ý và tự nguyện hỗ trợ cho các bạn, hỗ trợ cho dụng cụ để các bạn thực hành trong ngày chiều nay, và hỗ trợ cho tất cả các hội viên để tham dự. Tôi thực sự rất là trân trọng, và công ty Varian và tất cả các công ty Meradini cũng như là bây Việt Nam. I'm going to share with everyone. I don't invite to the company because I'm worried because this year many conference in imaging and then they okay. Oh, I have for your participant. Don't worry, log. I have for your participant. Yeah, by themselves. Oh, very honor, very pleasure. Bây Việt Nam, Medellin, variant Việt Nam also. Many. Thank you so much.
Xin cảm ơn.
And next, I would like to invite Mrs. Tang Chekhui, yeah, from Taiwan, and Professional Chung Kwang Hang from Korea, and Dr. Ho Kuei from Taiwan.
Mời thạc sĩ Thái Văn Lộc lên trao quà kỷ niệm.
And now, Mr. Thái Văn Lộc will be present some certificates from some present.
Xin
Thank
cảm
you.
ơn.
Thank you. And next, I would like to invite the professional Chi Feng Liu from Taiwan, Mr. Sohei Mito from Japan, and Mr. Ho Kwan Ta from Singapore, Mr. Mahesh Parameswaran from India, and Mr. Rakesh Kong from India.
Xin mời tiến sĩ bác sĩ Lê Tuấn Anh lên sân khấu. Xin cảm ơn.
Thank you. And next, I would like to invite Mr. Bragan, Hong Lung Liu, Hong Kong. Mr. Ho Kuei Yin, Hong Kong. Mr. Chi Lung Yin, Hong Kong. Mr. Joseph Lee, Hong Kong.
Xin mời bác sĩ chuyên khoa 2 Trương Quốc Trương lên trao giấy chứng nhận và quà tặng. Xin cảm ơn.
Thank you.
Trước khi kết thúc chương trình, xin mời tất cả mọi người cùng lên sân khấu chụp ảnh lưu niệm. Dạ. Mời
Now I would like to invite all the people in this conference to come to the stage for take some photo.
xin mời tất cả mọi người cùng lên sân khấu chụp ảnh kỷ niệm à.
Dạ. Dạ, mời mọi người lên sân khấu chụp ảnh kỷ niệm à.
Đây là chụp hình tập thể, xin mời tất cả mọi người mình lên mình chụp tấm hình tập thể nha, để lưu niệm thôi, rồi sau đó mình sẽ phân ra hai hội trường để tiến hành hội thảo. Ok, sinh viên mình có thể đứng sau lưng được. Ok. Bắt luôn không? Bắt luôn, ok. Ok, đây, đứng. Không. Đó. One more, one more, one more. One more, one more, one more. Okay, 1, 2, 3. Okay, thank you everyone. Thank you.
Mời tất cả mọi người mình tiến ra sảnh chụp với banner một tấm hình nữa nha. Everyone here. Chương trình khai mạc đến đây là kết thúc. Tiếp theo chương trình khoa học hội nghị, các bài báo cáo sẽ được chia làm hai hội trường kỹ thuật hình ảnh y học và hội trường xạ trị.
This opening ceremony has now come to the end. Next, we move to the scientific program we have to hold.
Xin nhắc lại, hội nghị đang được trực tiếp trên hai Zoom Medical Imaging, hội trường kỹ thuật hình ảnh y học, và Zoom Radiotherapy, hội trường xạ trị, và trực tiếp trên kênh YouTube và YouTube.
Please remind us that the conference is being broadcast live on the YouTube channel of VART, consists of both Zoom One Medical Imaging, Zoom Juice Real Therapy. Thank you and enjoy.
Alo, alo. Các anh chị mình tham dự hội trường bên hình ảnh học thì mình ngồi lại tại chỗ nha. Còn các anh chị mình tham quan bên tham gia bên hội trường xạ trị thì xuống tầng hầm B1. Mình có thể ngồi dồn lại giùm ha. Someone to
Dạ bây giờ là xin bắt đầu hội nghị kỹ thuật hình ảnh y học ạ. Xin mọi người còn ở ngoài sảnh vào lại để mình đầu phiên ạ. Dạ, bây giờ xin bắt đầu, phiên chủ tọa đàm của, Hội trường Kỹ thuật Hình ảnh Y học ạ. Dạ, giờ em xin mời tiến sĩ bác sĩ chuyên khoa 2 Đặng Vĩnh Hiệp ạ, là chủ tọa đàm phiên 1, bác sĩ chuyên khoa 1 Phan Công Chiến, giáo sư chuyên phân tử professional, chuyên phân tử from Thailand.
Good morning, distinguished and colleague. Welcome to the session Nuclear Medicine and Radiotherapy. My name is Đặng Vĩnh Hiệp, head of the Imaging Technology Department and from Thạch University of Medicine. I'm very happy to this session chairman and with two colleagues, Nguyễn Công Chiến from Ho Chi Minh University of Medicine. Yeah. The second, Professor Chi Wen Liu, National Zen Min Chao Tung University and Taipei in Taiwan. Three speaker. The first, Professor Zhang Hunwan, resident, the Korean Radio Digital Technology Association. And Mr. Nguyễn Tấn Hiên and Nguyễn Thị Quỳnh Anh, Department Diagnostic Imaging Functional Exploration, University Medicine Sinmark Hospital. We are to session report. The first lecturer, artificial intelligence, intelligence applied to ultrasound. The second presentation, one, Presto MRI clinical application and practice experience, University Medical Sinmark Hospital. Now, let me introduce our distinguished speaker, Professor Jun Hao Wan, President of Radiological Technology Association, please.
Good morning, everyone. I'm very pleasure attend this conference. Yeah. Okay. Now, my name is Han Jung-wang. I'm work for Samsung Medical Center, and I am president of the Korean Radiological Technologists Association. I'm very happy to meet you in Ho Chi Minh City, a wonderful city. I first visit Vietnam and Ho Chi Minh City. Yeah, I'm very happy. I'm very excited to make a presentation about AI in the field of ultrasound. From now on, I will present the topic of the latest AI-powered ultrasonography. Okay, AI, as you know, an umbrella term to describe the application of medicine. Machine learning algorithms and the other cognitive technologies in medical settings. In the simplest sense, AI is when computers and the other machines mimic human cognition and are capable of learning, thinking, and making decisions while taking actions. AI involves the use of algorithm to train machine to perform tasks that otherwise require human intelligence. For AI to be applied to things you see are involved data. Science is the area that includes the scientific and statistical methods of correcting, analyzing, interpreting data, and deriving information for decision making. Big data is refers to large amounts of data that are difficult to process with traditional data management and analytic tools. Machine learning is a subset of AI with the ability to train machines to perform tasks indirectly through exposure to more and more data over time. Deep learning is a subset of machine learning that can analyze complex data sets and form connections by operating similar to neural networks of the human brain. Why use AI in medicine? Because of shortage in experienced physicians, variations, and human errors, repetitive tasks. Let's take a moment to learn about ultrasound. Ultrasound is handled of ultrasound machine by the inspector directly, and the inspection image is obtained in real time to simultaneously direct and interpret abnormal findings. It generates continuous video streams that must be continuously analyzed. Given that a typical ultrasound device usually provides an image of 20 to 40 frames per second, approximately 12,000 to 48,000 frames per inspection, that takes about 10 to 20 minutes should be reviewed. If 10 to 20 patients are tested per day, a maximum of 120,000 to 960,000 frames per day may have to be evaluated. If you miss an important scene in such a large amount of frames, it can have a significant clinical impact. So it's effective. The development of AI systems requires significant clinical technical applications. What would be good if AI was applied to ultrasound? First, improve diagnostic accuracy. AI provides diagnostic information by analyzing ultrasound imaging. It helps to analyze certain diseases, such as breast cancer, for example. It can detect and diagnose the health condition of the fetus more accurately. Second, automate diagnosis and increase efficiency. In the past, there was only one diagnosis, but now AI is making various diagnoses be able to do it at the same time. For example, AI, which can automate heart disease and make 39 major diagnoses at the same time, it also being developed. This allows doctors to perform tests faster and more efficiently. Third, expand and standard access. AI helps obtain stable ultrasound image of high diagnostic value from experienced doctors or examiners, and also contribute to standardization of tests. Let's take a look at the major applications of ultrasound inspection AI. Side node real-time detection automatically detects informs you, allowing more accurate diagnosis. Ultrasound tests can vary depending on the skill level of the examiner, and in particular, AI supplement the accuracy of breast ultrasound test to help make more objective diagnosis. Ultrasound technology for maternal and fetal care is also developing a lot, and ultrasonic probes equipped with AI-based real-time image recognition uh, have been developed to help care for high-risk mothers. AI-based ultrasound automatically measure six key indicators, including placenta position, fetal posture, and gestational week. In addition, technology has also been developed to accurately diagnose fetal heart disease by combining high resolutions ultrasound and AI. Uh, the expected analysis of the forecast 2024 to 2034 market size of the ultrasound imaging field to which artificial intelligence is applied is as follows. The global AI in ultrasound imaging market size is estimated at 1.03 billion US dollar in 2024 and is predicted to surpass around 20.235 billion US dollar by 2034, expanding at a compound annual growth rate of 8.6% between 2024 and 2034. Now let's look at a few cases of artificial intelligence being applied to ultrasound. Left side abdomen scanning, right side abdomen scanning, left side liver and kidney, right side image spleen scanning, using a based automatical measurement in standard abdominal scan, keystroke or repetitive tasks may be reduced. It will be possible to test by reducing keystroke by 43%. And let's take a look at the steatotic liver and liver fibrosis. If the hepatocellular inflammation and the necrotic persist in alcoholic hepatitis, fatty liver, and viral hepatitis, hepatic fibrosis occurs, and if hepatic fibrosis progresses further, it eventually transition to cirrhosis. This is a picture of metabolic dysfunction associated with steatotic liver disease. First, normal liver and fatty liver, and fibrotic liver and the cirrhotic liver diagram. Fatty liver can be evaluated using quantitative ultrasound, and the liver fibrosis can be evaluated using shear wave elastography. Quantitative ultrasound diagnosis of fatty liver, shear wave elastography diagnosis of the fibrotic liver. It's a quantitative ultrasound methods. Through ultrasound, quantitative evaluation, not qualitative evaluation between fat is possible. There are tissue attenuation imaging, is the TAI, and the tissue scatter distribution is TSI method. TAI is quantifying and providing the degree of attenuation of tissue that depends on the amount of fat distribution in the liver. TSI is a way to quantifying signal distribution based on backscattering. healthy liver and severe fatty liver were evaluated by TAI and TSI through ultrasound. The fraction of the fat in healthy liver was analyzed below 3%, and the percentage of severe fat was analyzed at 29.88% fat fraction. This image is a comparison of the comparison of liver and kidney equals as a method of evaluating citing fat liver, and in case of severe fat liver, the brightness of the liver and kidney appeared to be significantly different. Let's look at the quantitative measure of hepatic fat. Provide three simpler quantitative indexes support to diagnosis liver steatosis. There are three methods of liver quantitative qualification. Compare bright level of liver and kidney, measuring attenuation of US ultrasound signals, quantifying scattered signal distributions. Quantitative measure of hepatic fat is both TAI and TSI apply. Report fat fraction obtained by scanning TAI and TSI 5 times each. Fat amount estimation evaluates the amount of fat estimated by USFF. USFF is ultrasound fat fraction. Ultrasound fat fraction is fat amount estimation in liver using regression. Increase clinical usability by providing the value correlates with MRI PDFF estimation of fat fraction use QSS parameters through the quantitative ultrasound by AI, improve the accuracy through the latest AI technology and multi-center data. Report fat fraction world data obtained by TAI and TSI is regression-based fat fraction in report. Fat fraction is 4.53%. The new deep USFF further increased the accuracy of fat fraction. Look at the correlation with archiving enhanced AI performance through diverse multi-center engagement. AI world 75% similar compared to MRI examination with deep USFF, a new method. 89% similar results were obtained. Deep USFF is offers improved usability and evaluate accuracy in quantifying liver steatosis. Ultrasound fat fraction was applied through deep learning of data obtained from several patients and comparative learning of RF data and MRI data. As you can see, it can be confirmed by reliability indicator column map of estimated fat fraction. And map column map of estimated fat fraction. Estimated fat fraction value. Let's take a look at shortwave elastography. Its ability to measure liver fibrosis in real time based on tissue stiffness and hardness. Calculate the shortwave speed versus tissue displacement map corrected using time information by sending a short by sending a shell wave ultrasonic beam into the tissue and display the module of elasticity value obtained with the shear modulus. Shear modulus G is the value obtained as a square of load times Vs. The unit of notation is kilopascal. Deep, sorry. Okay, hepatic fibrosis can be diagnosed non-invasive through shear wave ultrasound. F1 is normal liver, 4.4 kilopascal. F2, significant fibrosis, 6.8 kilopascal. F3, advanced fibrosis, 8.9 kilopascal. F4, cirrhosis liver, 16.6 kilopascal. Let's take a look at live liver assist function. In a study to Dasberger et al. Surveillance imaging and alpha protein for the detection of hepatocellular carcinoma in patients with cirrhosis detects of early hepatocellular carcinoma in cirrhosis patients increased from 21.4% to 88.9%. Real-time scans using live liver assist were able to detect suspicious local lesions with more than 80% accuracy. If you look at the clinical value from this result, beginners concerned about missing a lesion during liver scanning. Expert experienced clinician in detecting such a liver lesion that may be easily overlooked. Physician working in medical checkup center supports clinician in high volume screening setting by reducing human error and enhancing consistency in liver lesion detection. Detectable lesions are hemangioma, FNH, hepatic adenoma, focal fat sparing, focal fat deposition, HCC, cholangiocarcinoma, metastasis, liver abscess, etc. Third, harmonic imaging. Remote imaging using ultrasonic waves can be divided into fundamental imaging and harmonic imaging. Fundamental imaging consists of images by transmitting the transmission frequency of ultrasonic waves at a low frequency and receiving them at the same frequency. Because the transmission frequency is low, imaging can be performed to deep area, but resolution degradation occurs. On the other hand, increasing the transmission frequency increases the resolution or decreases the two depths of the images. Therefore, harmonic imaging technique is used to increase the resolution by transmission using a low frequency at the time of transmission and receiving a secondary harmonic at the time of reception. Harmonic images using twice the frequency improve contrast or resolution and reduce noise. For example, side robot effect, defibrillation effect in the image. Therefore, during the diagnosis process, using ultrasound images, the characteristics of the region can be accurately observed with the naked eye by improving the accuracy of the diagnosis result. It maximizes the resolution and the contrast of the imaging by utilizing finer and more refined third frequency signal and second harmonic. As a result, it's possible to clearly express the boundaries of a small structure that were difficult to distribute with the existing technologies such as pancreas and microbial ducts, further increasing the accuracy of diagnosis. The image on the left is a fundamental image, and on the right is a harmonic image, where low is removed so that the region can be clearly observed. Harmonic has been upgraded, so the harmonic images technology that uh, utilizes the frequency components of the ultrasound beam 3 times the transmitted frequency, developmentally to extract the third harmonic components from the huge quality received signal on AI filter for third harmonic were designed uh, using deep learning that allowed the effective extraction and utilization of the third harmonic signal. This is an image of the process of signal processing, the fundamental image and the third generation harmonic images. The application of AI can reduce workflow in obstetric view assist and biometry assist. Fully automated one-click view recognition and measurement for fetal biometry and heart improve efficiency and consistency. It's now possible to reduce keys by more than 57% to get the images by learning 43 views. More than 100 measurements were automatically applied. And biometry assist is a function that automatically measure by parallel diameter, BPD, head circumference HC, terminal circumference AC, or femur length FL, and the humerus length HL, which are items for measuring fetal growth. The final measurement is a function that allows medical staff to choose to help measure fetal growth. And in uterine assist measured uterus size, shape, and the uterus control extracts central line thickness of endometrium, providing a 3D coronal view. Gynecology uterine assist with only to keep track in adults at the view. Part of this for adult is fully automated one-click view recognition and measurement for adult for exam improve efficiency and consistency. When applied to the adult echocardiac at the previous 270 keystrokes consisted of only 27 keystrokes, making it possible to obtain 27 measurements through 10 view. Use the AI-based auto measurement, reduce keystroke 44% for repetitive tasks in standard abdominal scan, bladder assist and prostate assist in the after time automatic detection of bladder volume and the prostate lesion will be applied. This is bowel assist. Bowel assist is auto measurement tool to measure bowel wall thickness. Also, we provide a bowel report to input a diagnosis result description easily. This is nerve tract detection and provide the location of nerve area in real time during ultrasound scanning. The box is nervous tracing the scanning only available while using the nerve track feature further applied to 2 to 18 megahertz transducer. Nerve track with segmentation is nerve segmentation is the possible auto nerve tracking with segmentation. If you use nerve track with nerve measurement for carpal tunnel syndrome is automatically possible. Carpal tunnel syndrome is a common entrapment neuropathy caused by compression of the median nerve at the wrist. The cross-section area and the flattening ratio of the median nerve are used in diagnosing carpal tunnel syndromes. The cross-section area up to 11 millimeter square, flattening ratio up to 3 applied the area key to the nerve location. Scan the area to see if your nerve is pressed. If median lobe is swelled, if median lobe swelled up to 11 millimeter square, duration 6 months ago, median lobe. Cross-section area 11.3 plus 0.3 millimeter square, duration for more than 12 months, median lobe cross-section area 18.1 plus 0.3 millimeter square. By applying a live view assist in the fetal examination, you can archive the following efficient result. Clinical operational efficiency less, explore fetal medicine applications. It can check the automatic classification, annotation, and measurement of AI based through live view assistance. It's automatically saved during obstetric examination and automatically update when good view are confirmed during examination. This slide is an example that applies to obstetric ultrasound 3D view. Even blurry or obscured part of the fetus face can be literally Currently, 3D reconstruction can be applied to facial image the fetus. Even with reduced keystroke, it's possible to reconstruct the fetal face to reveal a more lovely images. Thyroid ultrasound image using Isrrt-Rt. The imaging classifies lexicons based on ATA, BTA, EU, TIRAD, and KTRAD for standardized classification, analysis, suspicious lesion, and generate report to reduce time from repetitive tasks. ATA is American Thyroid Association, BTA the British Thyroid Association, EU TIRAD, European Thyroid Imaging Reporting and Data System, KTRAD, Korean Thyroid Imaging Reporting and Data System. Yeah. Becomes an addition diagnosis method for the diagnosis of thyroid nodules and improves the diagnostic performance of less experienced radiologists. But in the United States, the classification items of SD test for thyroid are not automatically provided. And also the recommendations about whether result are benign or malignancy in S-detect for thyroid are not applicable in the United States. It's AI in breast US. Breast US is AI CAD systems are generally divided into two categories, CADE and CDX, based on the primary function. CADE is computer-aided detection, focused on identifying potential lesions or abnormalities within medical images. CADX, computer-aided diagnosis, make a differential diagnosis for the detected lesion, benign versus malignancy. Let's take a look at the paper on the useful of AI application in breast US. In a recent prospective study evaluating the usability of CAD AI breast for the clinical efficiency in real-world clinical setting were initially evaluated in 33 patients. The time of 14 malignancy, 17 benign, 2 normal cases. At Taiwan General Hospital, yeah. In the study, CAT-AIB for breast detected all malignant lesions without missing through real-time functionality with single performance of 0.835 and 0.5 of malignant probability and B I less 100% for sensitivity and 52.6 for specificity. In addition, the biolab categories for malignant cases were consistent with expert of the benign lesions. 50% were classified by biolab 4A or 4B, while expert classified to 72.2% as 4A or 4B, suggesting the possibility of reducing unnecessary biopsies. This image is elastoscan and E-strain. Elastoscan is a function of imaging the elasticity of tissue which observed the strain tissue that in deformed by internal or external forces convert the relative stiffness of the tissue into color images. It also comes with a 2D images so that you can check the location of the region of interest. And Isrrt-Rt is designed to facilitate and quickly calculate the strain ratio between two ROI regions. Isrrt-Rt, which allows for accurate and consistent result by simply setting two locations, helps you make informed decisions in different types of diagnostic. This is as detected for breast. This data was provided by Samsung Medicine. Using images obtained from breast ultrasonography, the standard classification of breast disease classified by biology, vocabulary, and analyze suspicious lesion to generate a report. As detected for breast is a function that analyze the selected area during breast ultrasound and show the analyzed data. Supported by bilateral atlas to provide standardized reporting to aid in diagnosis and simplify the workflow. As you can see, it analyzes various data such as the shape of the lesion, the echo pattern to inform you of the possibility of malignant tumors. It can also provide biological grade the lesion or use the detect for breast. This helps the doctors interpret the breast ultrasonogram and reduce the learning curve for less experienced sonographer. In the United States, only shape and orientation in the classification item of S-Detect for breast are automatically recommended. And also the recommendation about whether result benign or malignancy as detected for breast are not uh, applicable in the United States. This is live image. This image is a real-time lesion detection of a breast imaging imaging real time during scanning to identify areas suspected lesions. And it's also possible to make to biological grade by applying biological breast imaging reporting and the data system is provided standardized reporting and as in diagnosis with your simplified workflow. And through the live breast assist workflow from screening and the diagnosis reporting is streamed. What techniques are used in echocardiography? Doppler ultrasound and color Doppler ultrasound and the strain imaging and the contrast imaging. Doppler ultrasound, this technique shows how fast your blood flows and also in what direction. Color Doppler ultrasound, this technique also shows your blood flow, but it's use different color to highlight the different direction of flow. Strain imaging, the approach shows changes in how your heart muscle moves. It can. Okay, I see. Yeah. And several techniques can be used to create images of your heart. Best technique depends on your specific condition and what your provider needs to see. These techniques include two-dimension ultrasound, three-dimension ultrasound. What does an echocardiogram shows? On echocardiogram can detect many different types of heart disease. These include congenital heart disease, each other disease. What do we need AI in echocardiography? To reduce the fatigue of cardiologists and sonographers, shorter examination time. 90% of sonographers experience work-related scheduled, and AI algorithm can automate the analysis of echocardiographic images, reducing the time and effort required for manual interpretation. Okay, pass. Yeah. But quickly train and 2D world motion tracking and the 3D world motion tracking and the strain is a function that enables quantitative measurement of total and partial wall motion of the left ventricle. Natural value analysis confusion is and the measurement assist and 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 okay. So AI could help make healthcare operation more efficient. AI has a potential to improve the healthcare user experience. AI could be used to increase efficiency in healthcare diagnosis. AI is healthcare organization could mean better health monitoring and preventive care. As AI is integrated into ultrasound medicine, it's revolutionizing the medical imaging field and improving diagnosis accuracy and clinical efficiency. Beyond AI is supportive role in helping healthcare staff. It improves the quality of care and enable more people to access adequate healthcare that will continue to develop in a way that helps to receive it. Into ultrasound AI is very helpful in shortening the scanning time and checking the presence or absence of the disease in real time. In order to obtain information that is helpful in diagnosing a disease through AI, it's necessary to scan the area where the sonographer examines it with an accurate test method. Through these skills, person can quickly obtain images that are helpful for diagnosis, and the beginners can be provided with a shorter test time and information. Thank you for attention, and special thanks to you very much to Samsung Medical Center and the Canon Medical for providing the materials for today's presentation. If you have any question, yeah.
Thank you, Professor Yun Wan Han for Isrrt-Rt-Rtt in presentation. Now we have a time short and 1 and 2 question from audition now.
Okay, so do we have question from audience? No? Oh, very quick response, very good. So I think, no, I do have question for you. So don't run, okay? We still have like maybe just 1 minute for one quick question. You mentioned a lot of beautiful products about AI used in ultrasound. It can be used to automatically detect, for example, lesion or major, for example, the fatty liver or something else, even detect a nerve. But based on my personal experience in clinical environment, around 20% of the ultrasound imaging actually come with poor quality. That means that is not good enough. So when you apply the AI on these poor, bad ultrasound imaging, actually all the detection, automatic detection will fail. So my question would be, do you know there is any product that can detect the quality of ultrasound or even send a warning message to the operator saying about you should change the angle, the depth or something to improve the quality so the subsequent or following AI can work properly? Yeah, thank you.
Yeah. No. These materials I have now distributed include the contents that are currently being developed and will be well adapted to Korea. Yeah, and in the world. Yeah. Okay. Yeah.
Yeah, thank you.
Thank you.
Thank you, Professor. Yeah, yeah.
I don't like cats.
No, this is not a question. This is for the explanation which you asked. So most of the AI models which are using now have explainable AI. Because if, for example, if you're doing a wrong thing, for example, if I say in MRI, we select a wrong T or a wrong T, it will give an explainable AI. You are selecting a wrong thing because of this. That's called explainable AI. Most of the AI models, they're having this explainable AI as a salient feature.
The image rather than just checking the parameters or something. So I think that is the future. We need to make sure the image quality and we use the qualified imaging to do the automatic detection or diagnosis. That is the key. So thank you for your feedback. Okay. So let's proceed to the next presentation, right? We do have another
Okay, thank you.
question from the president. You cannot say no.
Okay. Not question for you. Okay, thank you, President Korea. I want to tell which not only everybody in here, in the world now, in Vietnam, in radiographer, not yes do ultrasound. We start in have a program like yesterday.
siêu âm
He and me visit the medical center.
hôm qua
Have
thì
a
chúng
long
tôi cũng
time
đến thăm
history ultrasound Vietnam.
trung tâm medic
Now,
ban đầu trong
Ministry
siêu
Healthcare
âm lớn
and Ministry Education in Vietnam request for me set up one program for radiographer and do ultrasound. Before, only radiologists. And reason, that's the reason many countries in Europe, in many companies, ask me how guest data ultrasound in Vietnam for AI deep learning get label for AI very difficult because we have a mid test. Last time in Vietnam, radiologists they do ultrasound and then usually they not enough scan for appendicitis. For appendicitis, for example, appendicitis, they thinking, oh, patient have appendicitis. They focus appendicitis, and then got the data not enough for AI learning, deep learning. And then I tell with many university in another country, and Japan also asked me how long I want to get data ultrasound for abdomen. Oh, sorry. In Vietnam, radiologists, they not enough the scan ultrasound, not enough the data. For example, like Professor Lu, you thinking patient, oh, bend here, okay, focus, one scan, two scan, three scan, enough. I know this, not enough for AI deep learning. And then now I want to share with everybody in Korea, in Taiwan, in some of Europe. We building now. We building one program for radiographer can do ultrasound from now. Okay, I want to share for everybody. Okay, not question for you, my brother. Don't worry. Okay, thank you. Thank you.
Yes, thank you, Professor Yun Han Yuan. Okay. Yes. Now, let me introduce a distinguished speaker, Nguyễn Tấn Hiền and Miss Nguyễn Thị Quỳnh Oanh. Presentation one, Reto MI clinical application and practice experience at University Medical Sinmark Hospital. Please.
Xin chào quý ban chủ tọa đoàn, ban tổ chức hội thảo, ban giám đốc bệnh viện và toàn thể anh chị em đồng nghiệp đang tham dự trực tiếp tại hội trường cũng như là trực tuyến trên màn ảnh. Em tên là Quỳnh Oanh, cử nhân chẩn đoán hình ảnh, hiện đang công tác tại Bệnh viện Đại học Y Dược Sinh-Mắc. Đến với hội thảo ngày hôm nay thì em cùng cử nhân Nguyễn Tấn Hiển hiện đang công tác tại viện. Xin được phép báo cáo bài hội thảo với chủ đề là Isrrt trực tràng, ứng dụng và kinh nghiệm thực tế tại viện. Để mọi người có cái nhìn tổng quan trước khi đi vào nội dung chi tiết, em xin điểm qua bố cục chính của bài báo cáo sẽ là bao gồm vai trò, kỹ thuật, ứng dụng, kinh nghiệm và những cập nhật mới. Mở đầu chúng ta sẽ nhìn lại bối cảnh và vấn đề đặt ra trước khi đi sâu vào vai trò của Isrrt trực tràng. Ung thư trực tràng là một bệnh thường gặp, đặc biệt là ở các nước phát triển với tỷ lệ mắc cao nhất ở các nước phương Tây. Theo số liệu của Globocan 2022, ung thư trực tràng là loại ung thư phổ biến thứ 3 trên toàn cầu với khoảng 1,9 triệu ca mắc mới, là loại ung thư gây tử vong cao thứ 2 trên thế giới. Tại Việt Nam, ung thư trực tràng nằm trong nhóm 4 loại ung thư phổ biến nhất, với đa số bệnh nhân được phát hiện ở giai đoạn muộn. Do đó, ung thư trực tràng đòi hỏi việc phát hiện sớm để chẩn đoán chính xác, giúp cho định hướng điều trị cũng như là nâng cao chất lượng cuộc sống cho người bệnh. Để đáp ứng được những yêu cầu như vậy thì hiện nay Isrrt đã trở thành một phương pháp tối ưu nhằm đánh giá giai đoạn cục bộ ở bệnh nhân ung thư trực tràng. Việc sử dụng Isrrt để đánh giá các khối u cả trước và sau điều trị bổ trợ ngày càng trở nên quan trọng và có thể ảnh hưởng đến quá trình phẫu thuật và điều trị của bệnh nhân. Trọng tâm của Isrrt là xác định các đặc điểm tiên lượng quan trọng và đánh giá ảnh hưởng của khối u này đối với việc đưa ra các quyết định điều trị. Tiếp theo chúng ta sẽ cùng tìm hiểu kỹ thuật chụp Isrrt tại viện. Để đến với phần kỹ thuật thì để có được những hình ảnh chính xác mang lại giá trị chẩn đoán cao thì việc chuẩn bị bệnh nhân là hết sức quan trọng. Thứ nhất là phải lên lịch chuẩn bị trước thủ thuật. Trước khi chụp thì bệnh nhân cần được nhịn ăn khoảng 4 đến 6 tiếng để giảm nhu động ruột. Đồng thời cũng cần kiểm tra chức năng thận để đảm bảo an toàn khi sử dụng thuốc đối quang từ. Thứ hai là phải kiểm tra an toàn trước khi chụp. Bệnh nhân cần hoàn thành bản kiểm an toàn, đảm bảo các yếu tố loại trừ các yếu tố chống chỉ định để đảm bảo an toàn trong lúc chụp. Thứ ba là cần phải chuẩn bị đại tràng. Bệnh nhân sẽ được thụt tháo khoảng 15 đến 60 phút trước khi chụp, mục đích là giúp loại bỏ khí và phân trong lòng trực tràng, giúp giảm nhiễu ảnh và tăng khả năng quan sát khối u. Thứ tư thì là thuốc giảm co thắt ruột. Trong một số trường hợp thì bệnh nhân sẽ được dùng thuốc giảm co thắt ruột để giảm chuyển động ruột, giúp hình ảnh rõ nét hơn, đặc biệt là khi chụp u trực tràng cao. Hiện tại thì bệnh viện đang sử dụng hệ thống máy GE Signal Creator 1.5 Tesla. Khi chụp MRI trực tràng thì viện đang sử dụng coil body. Với phần tư thế bệnh nhân thì bệnh nhân được nằm ngửa, chân hướng vào trong lòng máy, đặt bệnh nhân vào giữa bàn ở vị trí coil sao cho phần khung chậu được bao phủ hết. Đeo tai nghe chống ồn cho bệnh nhân như hình minh họa được chụp tại viện. Ờ, Đây là bổ sung đang sử dụng tại viện cùng với các thông số kèm theo. Đến với mặt phẳng sagittal là mặt phẳng đầu tiên, giúp định vị được quát toàn bộ trực tràng. Trên mặt phẳng này thì cần điều chỉnh FOV vào giữa trực tràng trên mặt cắt ASEAN và coronal bao phủ hết toàn bộ trực tràng. Hai mặt phẳng quan trọng nhất là mặt phẳng ASEAN và coronal oblique. Mục đích của coronal oblique là việc đặt mặt cắt đúng theo hướng trục ống hậu môn rất quan trọng để bộc lộ chính xác khối u trực tràng thấp và đánh giá tốt các mối quan hệ của tổn thương với cơ thắt hậu môn. Trên mặt phẳng ASEAN thì mục đích là nhằm đánh giá chính xác mức độ xâm lấn của tổn thương ra ngoài thành trực tràng, và khoảng cách giữa tổn thương với mặt treo trực tràng là một yếu tố quan trọng để đo CRM là diện cách chu vi phẫu thuật và xác định được giai đoạn T. Đối với các tổn thương ở gần hoặc liên quan đến ống hậu môn thì nên cắt song song với ống hậu môn nhằm đánh giá các tổn thương liên quan đến cơ thắt. Sau khi đã nắm được các mặt phẳng chụp cơ bản trong MRI trực tràng thì chúng ta sẽ đi sâu hơn với các chuỗi xung chủ đạo được sử dụng để đánh giá khối u. Chuỗi đầu tiên là chuỗi T2 FOV lớn. Mục đích của chuỗi này là cung cấp cái nhìn tổng quan quát toàn bộ trực tràng và xác định vị trí tổn thương chính để định hướng cho các chuỗi xung tiếp theo. Ở mặt phẳng ASEAN thì chuỗi này giúp đánh giá các hạch vùng xa như hạch mặt treo, hạch chậu, hạch bẹn. Còn trên mặt phẳng sagittal thì nó giúp đo chiều cao của khối u, xác định được mối liên quan giữa u và ống hậu môn cũng như các cấu trúc lân cận. Tiếp theo chúng ta sẽ đến với một chuỗi xung quan trọng trong chụp MRI trực tràng, đó là T2 độ phân giải cao, cho phép thể hiện rõ ràng các lớp giải phẫu của thành trực tràng. Với chuỗi T2 độ phân giải cao này thì MRI có thể đánh giá chính xác khoảng cách giữa khối u và mạc treo trực tràng trước phẫu thuật, từ đó phân biệt được nhóm bệnh nhân có nguy cơ thấp và nguy cơ cao tái phát tại chỗ. Ngoài ra chuỗi này còn giúp nhận diện các cấu trúc nhỏ của thành ruột. Như hình bên trái chúng ta có thể thấy là hai mặt thường được sử dụng để chụp chuỗi xung này là ASEAN và coronal, giúp đánh giá toàn diện tổn thương. Tóm lại thì xung T2 độ phân giải cao là chuỗi xung nền đóng vai trò chủ đạo trong lập kế hoạch điều trị và tiên lượng với bệnh nhân ung thư trực tràng. Sau khi đã đánh giá được các cấu trúc giải phẫu chi tiết qua chuỗi xung T2 độ phân giải cao thì chúng ta sẽ đến với chuỗi xung diffusion. Chuỗi diffusion với giá trị B cao, đặc biệt hữu ích trong nhiều tình huống lâm sàng, giúp phát hiện các mô u còn sống sau hóa xạ, nhờ phân biệt chức năng mô hoại tử và mô u, hỗ trợ đánh giá lại giai đoạn điều trị. Sau điều trị, ngoài ra thì diffusion còn giúp phát hiện hạch di căn, nhưng mà mặc dù thì độ đặc hiệu chưa cao vì hạch lành tính và hạch di căn đều hạn chế khuếch tán. Diffusion là chuỗi xung quan trọng không chỉ dừng ở hình ảnh cấu trúc, mà còn đánh giá được bản chất của tổn thương, đặc biệt là theo dõi sau quá trình hóa xạ trị. Hình minh họa cho thấy là hình ảnh diffusion cho thấy khả năng quan sát hạch rõ hơn so với hình tương ứng ở trên T2. Trên slide này là hai chuỗi xung T1 và T1 phát sát. Cả hai xung này thì đều không bắt buộc cho đánh giá giai đoạn. Chuỗi xung T1 không tiêm thuốc thì hữu ích trong việc phát hiện các tổn thương tình cờ như là nang, xương, buồng trứng. Với chuỗi T1 phát sát thì là dùng để so sánh, đối chiếu với T1 phát sát sau tiêm nhằm đánh giá mức độ ngấm thuốc của tổn thương. Tóm lại cả hai xung này đều bổ sung vai trò cho T2 độ phân giải cao và diffusion, giúp hoàn thiện đánh giá toàn diện. Tiếp theo là xung T2 phát sát. Xung này thì có lợi cho bệnh nhân rò hậu môn hoặc là áp xe kèm theo. T2 phát sát thì giúp làm rõ mô mềm, xác định được các cấu trúc xâm lấn trực tràng và theo dõi đáp ứng điều trị. Xung này thì giúp làm rõ các cấu trúc giải phẫu, đánh giá hướng lan của khối u và hỗ trợ lập kế hoạch điều trị chính xác. Tại viện thì sau khi mà chụp những chuỗi xung thường quy thì đang sử dụng T1 3D Lava Flex sau tiêm thuốc tương phản, đóng vai trò quan trọng trong phân giai đoạn toàn diện ung thư trực tràng, làm tăng khả năng tưới máu của mô bất thường, phát hiện được di căn mô mềm, xác định ranh giới và các cấu trúc bên trong khối u. Mặc dù không bắt buộc trong các quy trình thường quy nhưng T1 Lava sau tiêm thì được khuyến nghị khi nghi ngờ có di căn mô mềm, cần mô tả các chi tiết tổn thương dạng nhầy hoặc phức tạp. Ở một số trường hợp cần thiết thì, chúng tôi có thể sử dụng chuỗi xung 3D T2 Cube trước khi tiêm thuốc, nhằm mục đích là cung cấp hình ảnh 3D T2 với độ phân giải không gian cao, cho phép tái tạo đa mặt phẳng mà không cần chụp lại theo nhiều hướng, đánh giá chính xác, ranh giới khối u, mối liên quan với mặt treo trực tràng và các cấu trúc xung quanh, hỗ trợ lập kế hoạch, phẫu thuật và xạ trị nhờ khả năng dựng lại hình ảnh. Sau khi đã trình bày về các chuỗi xung trong chụp MRI trực tràng thì tiếp theo tôi xin giới thiệu 2 ca lâm sàng thực tế tại viện, nhằm minh họa vai trò của các chuỗi xung chính trong đánh giá đáp ứng điều trị sau hóa xạ. Ca lâm sàng thứ nhất, là hình ảnh trên slide là hình ảnh của MRI của bệnh nhân ung thư trực tràng giữa được chụp trước và sau hóa xạ. Trên chuỗi xung này thì, sử dụng gồm, T2 độ phân giải cao và diffusion. Sau điều trị thì, hình ảnh cho thấy khối u giảm kích thước rõ, tuy nhiên vẫn còn vùng tăng tín hiệu nhẹ trên T2 độ phân giải cao và hạn chế khuếch tán trên diffusion. Điều này cho thấy là bệnh nhân đáp ứng điều trị một phần và hình ảnh MRI ở giai đoạn này giúp đánh giá chính xác mức độ còn sót lại của tổn thương, hỗ trợ bác sĩ trong việc lập kế hoạch điều trị tiếp theo. Ờ, Sau đó sang slide này thì, là những chuỗi xung sau tiêm. Ta có thể có thêm thông tin về tưới máu và đáp ứng điều trị, hoàn thiện quá trình đánh giá sau hóa xạ. Ờ. Đến với ca lâm sàng thứ hai thì là sau hóa xạ thì hình ảnh cho thấy là, thành trực tràng trở lại đều, không còn khối tăng tín hiệu trên, T2 độ phân giải cao và hạn chế khuếch tán cũng biến mất. Đây là hình ảnh điển hình của việc, đáp ứng hoàn toàn hoặc gần hoàn toàn sau điều trị. Ca này minh họa rất rõ giá trị của MRI trong, việc xác định đáp ứng tốt với điều trị. Từ 2 ca lâm sàng trên thì cho thấy MRI đã giúp đánh giá được mức độ đáp ứng điều trị, từ đó giúp các bác sĩ lâm sàng có phương hướng kế hoạch điều trị đúng đắn hơn. Tại viện chúng tôi đang áp dụng, phần mềm Isrrt-Rt-Rtt, một công nghệ tái tạo hình ảnh MRI dựa trên, trí tuệ nhân tạo do hãng GE phát triển. Phần mềm này giúp tạo ra hình ảnh có tỷ lệ tín hiệu trên nhiễu cao hơn, độ nét và chi tiết mô rõ hơn, giảm thời gian chụp mà vẫn giữ được chất lượng hình ảnh ổn định. Trong thực tế tại viện thì khi áp dụng cho MRI trực tràng, thời gian giảm từ 38 phút xuống còn 19 phút, hiệu suất giảm 51%. Hình ảnh chất lượng cao hơn, giúp hỗ trợ bác sĩ chẩn đoán chính xác hơn, đặc biệt là đối với những tổn thương nhỏ cần phân giải cao. Đây là sang slide này thì, chúng ta có thể thấy rõ là hiệu quả của cái, phần mềm này. Hình bên trái là 2 hình trước khi sử dụng phần mềm, và hình bên phải là 2 hình sau khi sử dụng phần mềm. Thì, trước khi sử dụng thì độ phân giải thấp hơn, nhiều nhiễu hơn, các cấu trúc mô mềm vùng trực tràng chưa thật sự rõ nét. Còn sau khi sử dụng thì hình ảnh sắc nét hơn, độ tương phản mô được cải thiện, mức lớp giải phẫu trực tràng cũng được thể hiện rõ hơn. Nhờ vậy mà bác sĩ có thể đánh giá chính xác hơn giai đoạn bệnh tại chỗ. Từ đây có thể thấy là AI không chỉ giúp tăng tốc độ chụp mà còn mang lại giá trị lâm sàng thực sự trong chẩn đoán chính xác và quyết định điều trị. Từ quá trình triển khai và ứng dụng thực tế tại viện thì chúng tôi cũng rút ra được một số kinh nghiệm lâm sàng và kỹ thuật quan trọng trong chụp MRI trực tràng, xin được trình bày ở phần tiếp. Ở hình A và hình B thì, chúng ta có thể thấy là hiệu ứng nhiễu ảnh do kim loại tạo vùng, mất tín hiệu quanh clip gây, khó khăn trong đánh giá tổn thương. Còn ở hình B là còn có thể thấy được là nhiễu ảnh chuyển động, làm mờ nhòe ranh giới của các vùng chậu. Kinh nghiệm rút ra ở đây là cần hỏi kỹ tiền sử phẫu thuật và xác định vật có kim loại trước khi chụp, giải thích rõ cho bệnh nhân về việc giữ yên để giảm ảnh giả chuyển động. Trong thực tế là còn có các nhiễu ảnh khác, như là ở hình bên trái thì là hình nhiễu do khí ở trong trực tràng ở chuỗi diffusion. Khi có khí thì tín hiệu bị mất, gây dạ tổn thương hoặc là che khuất. Cách khắc phục thì là cần thục tháo kỹ trước khi chụp, hướng dẫn bệnh nhân đi vệ sinh và tránh ăn uống sinh hơi trước khi chụp. Hình bên phải là nhiễu ảnh do chuyển động hô hấp hoặc là nước tiểu trong bàng quang. Hơi thở làm mờ ranh giới mô, còn, nước tiểu gây hiệu ứng chuyển động. Cách khắc phục thì là cho bệnh nhân đi tiểu khoảng, 20 đến 30 phút trước khi chụp, làm cho bàng quang vừa phải, không quá căng cũng không quá xẹp, hoặc là đặt một tấm xốp ở giữa người bệnh nhân và co giúp giảm nhiễu ảnh, hoặc là và dặn bệnh nhân hít thở nhẹ nhàng. Từ kinh nghiệm này thì chúng tôi nhận thấy là việc chuẩn bị bệnh nhân kỹ lưỡng và phối hợp tốt trong lúc chụp là giảm tỷ lệ nhiễu ảnh rõ rệt ạ. Về việc, bơm gel thì, trong một số trường hợp vẫn có thể gặp nhiễu do khí còn sót lại hoặc là do bệnh nhân chưa phối hợp tốt khi nín thở. Chính vì vậy việc tìm hiểu rõ nguyên nhân và khắc phục trong từng tình huống rất là cụ thể, rất là quan trọng. Ở slide, tiếp theo thì, xin trình bày ví dụ minh họa trước và sau khi bơm gel để thấy rõ hiệu quả của kỹ thuật này. Hai hình bên trái là hình trước khi bơm gel, còn hai hình bên phải là hình sau khi bơm gel. Có thể thấy rằng là sau khi bơm gel, lòng trực tràng được giãn ra rõ rệt, nhờ đó ta có thể xác định được vị trí và ranh giới của tổn thương hơn, đặc biệt là trong các trường hợp lòng trực tràng xẹp hoặc dính sát vào khối u. Tuy nhiên thì, việc bơm gel vẫn còn đang nhiều tranh cãi. Một số nghiên cứu cho rằng là gel có thể làm thay đổi khoảng cách từ u đến mạc treo trực tràng, dẫn đến sai lệch khi đánh giá xâm lấn. Vì vậy không phải trường hợp nào thì cũng cần bơm. Tại viện thì protocol đang được xây dựng là cả gồm 2 chuỗi xung trước gel và sau gel để bổ trợ cho nhau. Xung trước gel thì, giúp giữ được hình thái tự nhiên của trực tràng, đánh đúng mối tương quan giải phẫu. Xung sau gel thì lại giúp lòng trực tràng tạo tương phản tốt giữa khối u và thành, hỗ trợ đánh giá ranh giới rõ ràng hơn. Từ kinh nghiệm thực tế thì có thể rút ra rằng là việc bơm gel nên áp dụng có chọn lọc, chú ý gel vừa phải, lượng gel vừa phải và chỉ sử dụng khi lòng trường tràng xẹp hoặc khó phân biệt ranh giới tổn thương nhằm đạt được hình ảnh tối ưu mà vẫn đảm bảo độ chính xác khi đánh giá MRF. Ngoài việc bơm gel thì việc đặt mặt phẳng chụp chính xác cũng là yếu tố then chốt để, ảnh hưởng đến độ chính xác khi đánh giá. Việc đặt đúng mặt cắt quyết định rất nhiều đến kết quả chẩn đoán cũng như là điều trị cho bệnh nhân. Ở phần thấp trực tràng thì đánh giá MRF phức tạp hơn do cấu trúc giải phẫu. Việc ảnh có chất lượng cao và định hướng lát cắt đúng là rất quan trọng. Như hình ví dụ minh họa về việc đặt lát cắt đúng ta có thể thấy là, ở hình, giữa thì mặt phẳng cắt ngang được đặt vuông góc với trục cơ thể. Thay vì, trục của khối u trực tràng thấp dẫn đến hình ảnh có thể gây hiểu lầm rằng là
Báo cáo
mặt
viên có thể nói ngắn lại.
dạ, mặt quanh trực tràng đang bị xâm lấn ở vòng trước. Ờ, từ những kinh nghiệm thực tế thì việc áp dụng, các, guideline quốc tế mới cập nhật thì, giúp cho kỹ thuật, được tốt hơn. Trong phần cập nhật về nguyên tắc cơ bản của mình thì, theo hướng dẫn mạng lưới ung thư toàn diện quốc gia của Hoa Kỳ thì, phiên bản 3 năm 2025 thì MRI vẫn được nhấn mạnh là phương tiện hình ảnh chuẩn trong đánh giá giai đoạn tại chỗ của ung thư trực tràng. Cụ thể là MRI vùng chậu có hoặc không tiêm thuốc đều được, chấp nhận, tuy nhiên MRI vẫn là lựa chọn ưu tiên để đánh giá. Ờ, tiếp theo là không cần bắt buộc phải bơm gel trực tràng và do còn tranh cãi. Máy tối thiểu là 1.5 Tesla, chuỗi xung cốt lõi là T2 độ phân giải cao với, độ lát cắt mỏng. Diffusion thì hỗ trợ đánh giá đáp ứng điều trị. Tóm lại thì chất lượng MRI vẫn phụ thuộc chủ yếu vào xung T2 và hướng chụp chuẩn chứ không nằm ở việc là có tiêm thuốc hay là bơm gel. Khác với diffusion thông thường thì diffusion tổng hợp được tính toán từ diffusion thu với ít nhất 2 giá trị B, giúp làm giảm mờ nền hiệu quả mà không tốn thêm thời gian quét. Ờ, đây là hình, diffusion, toàn cơ thể thì giúp khảo sát toàn thân, giúp phát hiện được tổn thương và di căn. Dạ, bài báo cáo của em, xin hết ạ. Em xin chân thành cảm ơn.
Xin cảm ơn báo cáo viên Quỳnh Anh đã cho chúng ta một bài báo cáo rất là hay về cái kỹ thuật MRI trực tràng, mục đích trong cái vấn đề phối hợp đa chuyên khoa. Như vậy với cái bài báo cáo đó cho chúng ta thấy 4 cái yếu tố rất là rõ. Thứ nhất về đối với bác sĩ ngoại khoa, bác sĩ phẫu thuật thì với MRI thì xác định rõ các cấu trúc giải phẫu, giới hạn xâm lấn ở mức độ. Ý thứ hai của cái bài báo cáo này là đối với bác sĩ ung bướu với nội khoa thì giúp đánh giá cái vấn đề đáp ứng với điều trị hay không. Chụp chúng ta theo dõi. Và cái vấn đề thứ ba nổi bật ở đây là đối với ung thư xạ trị thì MRI giúp chúng ta lập căn xạ trị để xác định chính xác cái tệ và cái và cuối cùng với cái vai trò chẩn đoán ảnh là connect, tức là phối hợp đa chuyên khoa giúp cho vấn đề điều trị, và đây là cũng là cái xu hướng liên quan giữa cái vai trò của kỹ thuật hình ảnh của chúng ta liên quan đến vấn đề chẩn đoán và giúp cho bác sĩ lâm sàng có những cái liên kết và điều trị hiệu quả hơn. Xin cảm ơn.
Thank you for your interesting presentation. Let me sum up this presentation again. Rectal MRI plays a vital role in diagnosing, staging, and assessing treatment response in rectal cancer.
With high-end techniques powered by AI and deep learning, the diagnostic accuracy and disease management continue to improve significantly. From a technical standpoint, while each hospital may follow their role, patient preparation and imaging protocols, the key principle remain consistent. The imaging plans must be precisely aligned with the tumor axis and fully encompass the lesion. Once again, thank you, Ms. Wang.
Yeah, so I'm the one who should announce the break time, right? Okay, 10-minute break, then we can come back. Is that okay? Is that okay? 10-minute break, right? Okay.
Now, thank you to all the speaker and participate for engageful discussion. Bây giờ chúng ta tiếp tục cái phiên tiếp theo. Anh Dũng, phiên tiếp theo. Anh Dũng có đây rồi. Xong rồi chương trình này team break tại chỗ thôi chứ không có mất hết thời gian.
We will direct insights. Yeah. So we continue the conference. Yeah. Continue. Và để bắt đầu phiên thứ hai, xin mời thạc sĩ Nguyễn Tuấn Dũng, anh Lưu Chú Dũng, Mr. Mahas Parameswara. Please welcome Mr. Nguyễn Tuấn Dũng, Mr. Lưu Chí Dũng, Mr. Mahas Parameswara for the role of chairman of this session.
Okay, now we want to the second session for the technologies. Imagine and the first lectures, I would like to introduce Mr. Choi Mito. She come from the here GF Radiation Technology Department, International University of Health and Welfare Medical Hospital, Chiba, Japan. So please welcome Mr. Choi Mito.
Xin chào giáp bì, tốt gặp quý vị. Okay. Tôi là Mito từ Nhật Bản. Tôi rất vinh dự được format tại đây và mong muốn chia sẻ những dữ liệu ý cứ với quý vị. So, our group operates 70 facilities across Japan. My workplace, Narita Hospital International University of Health and Welfare. We collaborate with over 3 institutions. We established the IUHW IUHW Health Checkup Center in partnership with Chorai National Hospital, marking Vietnam's first health checkup facility. Now, let me show you today's agenda. First, I will explain why we need to learn about AI. Next, I will discuss how AI supports our work. Finally, I will present AI technologies that are becoming standard in clinical practice. Let's begin. Okay. Sorry. Yeah, pointer is I want, but maybe this presentation is before previous presentation. Yes, I send you. Yeah, okay, so continue. Thank you. So now, first, let me explain why we need to learn about AI. What it is AI? AI is classified as this slide. ANI is also called narrow AI or weak AI. ANI is a system that specializes in running and processing tasks within a limited domain. ChatGPT is an example of ANI. AGI is expected to reach a cognitive level equivalent to human brain. Think of Doraemon. ASI is AI that exceeds human intelligence. So currently, AI is still developing. It is not all powerful. So this is a research of the Nobel Prize 2024. So everyone uses AI. Next. This shows the history of AI. Theories of machine learning and neural networks were developed in the 1970s. After that, AI advanced rapidly through deep learning. Paradigm shift in the image field occurred when Professor Hinston's AlexNet won ILS VRC 2012. Previously, we designed features manually. However, in deep learning, if sufficient data is available, the machine automatically extracts features. This is the key innovation. What is happening in current medical practice? This slide shows FDA approved AI and machine learning medical devices in the United States. 85% of them are imaging related AI medical devices that use images as input, which directly relates to our work. Main applications include quantification and future localization, image enhancement, detection, diagnosis, and acquisition guidance. The combination of medical images and AI demonstrates strong compatibility and plays a major role. So there are three main types of AI model bias. First is data bias. If you use data bias for a specific country, hospital, imaging equipment, age, race, or disease, there will be a deviation from the true distribution. Next is method bias. This refers to the structural bias inherent in analysis methods like CNN. Finally, there is cognitive bias. This occurs when developers unconsciously select data or when physicians' judgments are reflected in the trained data. To work effectively with AI that has these characteristics, I believe we must understand AI thoroughly. For post-market retraining of software as a medical device, data management and regulatory preparation for performance evaluation are urgent priority. Next, I will discuss how AI supports our work, starting from the fundamental. These are deep learning models and tasks commonly used in medical imaging. They are applied to image classification, object detection, segmentation, and image enhancement. CNN convolution, that is, convolution neural network is widely adopted. Artificial intelligence encompasses any technology that enables the imitation of human behavior. Its subfield is machine learning. Below that is deep learning. CNN is one method within deep learning. Machine learning is a technology that enables computers to learn patterns and rules from data and make predictions and decisions without being explicitly programmed. For example, SVM, decision tree, and random forest are included. Deep learning also included here. So what is deep learning? A biological neuron receives signals through dendrites and transmits electrical signals to other neurons through axon. And artificial neurons multiplies input by weight and bias applies an activation function. And produces an output. Deep learning employs multi-layered neural networks modeled after the human brain to learn from data. In deep learning, we do not need to manually select features. AI learning methods include supervised learning, unsupervised learning, and reinforcement learning. In the medical field, correct answers are often clearly defined, and supervised learning is widely adopted. The key is high quality data with clear preference regarding who created it and how. So from here, I will discuss the fundamentals of DCNN. This diagram illustrates the mechanism of using CNN to extract features from input image and classify them. On the left is the input image. On the left side of the figure, there is an input image with numerical values. The 3x3 filter in the center scans this image as indicated by the red frame. At each position, it multiplies the values within the window by the filter values. For example, at the red frame position, oh, do not, sorry, animation is down. Sorry. Okay, I explain this. So you multiply and sum the corresponding 9 numbers in the images with each value of the filter during training. The parameter that the model can automatically adjust are weight W and bias B. With filter weighting like this, as shown in this slide, filters such as a sharpening, edge enhancement, or strong sharpening are created. The filter values are determined automatically by the model during training. This figure shows the spatial arrangement with height depth of the output value obtained after the input image passes through the convolutional layer. Spatial resolution is expressed by width and height, while the number of filters is expressed as depth. The ReLU is the activate function. It's a pixel by pixel operation that replaces all negative values with 0. It's a non-linear operation. This more strongly emphasizes features. Max pooling has a role of efficiently extracting only representative features while reducing the size of images and future maps. Additionally, it becomes robust to slight spatial shift. So lower layer neurons run simple features like line and dots. Middle layers run components such as eye, ears, and nose. Upper layer run more complex features like human face, like this. This slide shows the architecture of deep convolutional neural networks. In this diagram, The CNN has a multi-layer structure. Future learning extracts features from images. Convolution and pooling layers output high-level features from input. Flatten converts two-dimensional features into one dimension. The fully connected layer uses these features to clarify the input image. Softmax express the output as a probability of the image belonging to the particular class. The loss is calculated from the probability and the level using the loss function. Loss is a numerical representation of how much the neural network's prediction deviates from the actual correct answer. For classification task, cross-entropy loss is commonly used. Minimizing this loss becomes the network's learning objective. The error calculated by the loss function is propagated backward from the network's output layer toward the input layer. Through this process, we calculate gradients to determine how the weights and bias of each layer should be adjusted according to error magnitude. And we proceed with training. So far, I've been discussing classification, but consider this diagram. The future extraction component of the deep CNN is called the backbone, while the task-specific component is called the head. By keeping the bone fixed and changing the head, you can perform tasks such as classification, object detection, segmentation, and other specialized functions. This is a classification breast cancer screening. So doctor AI is better than the doctor. This is a indicates. Instead of classifying the entire image into one category, this method is designed to identify which object of or semantic meanings are present at each pixel of the image. By replacing fully connected layers with convolutional layers, it becomes possible to predict the category of each pixel while preserve the spatial information of the image. So this is a cell segmentation task using the UNet. So what is a UNet? UNet has a symmetrical U-shaped architecture. The horizontal gray arrow like this represent skip connections, which directly transfer information from the encoder to the decoder to restore fine details. This model excels at precisely delineating which part of the image presents what. As applications by modifying the architecture and trained data, you can perform denoising or super resolution of medical imaging. So from here, I will discuss the utility and operation of AI referring to medical equipment incorporating AI from Japanese manufacturer. Conventional noise reduction processing manually created rules to separate signal from noise. Intelligent NR is a technology that uses deep learning method to learn the characteristics of noise contained in X-ray images and applies the trained model to reduce noise from captured images. This shows a training process. They utilize a database of thousands of images. Through simulation, they add noise to image to generate tens of millions of training samples. The image on the right presents the ground truth without edited noise. The output becomes the inference result image. They compare it with the ground truth and update parameters to minimize loss. This image shows a noise component images from each image processing method. The INR image contains significantly less noise. Compared to conventional processing, we can reduce noise up to 50%. The top row shows conventional processing, and the bottom row shows INR images. From left to right, before processing, after processing, and the noise component extracted from the pre-processing image. Conventional noise reduction accidentally removes some signal components. INR contains almost no signal in the removed noise. INR can selectively remove only noise without affecting the signal. So this is a comparison of those levels and noise reduction images for frontal chest X-ray images. The center image is an INR image with a dose reduced by half. The right image is a 50% dose image without noise reduction applied. Like this zoom is here. So this is advanced real-time image processing using deep learning. Fluoroscopic image quality approaches that of radiographic images. This slide demonstrates the evolution of fluoroscopic image quality using deep learning compared to radiographic image quality. It achieves equivalent image quality with a 50% dose reduction and displays images in real time. This is ideal for clinical procedures such as guide wire manipulation. So, okay. Deep learning reconstruction DLR as a image reconstruction technology utilizing AI achieves both reduced radiation exposure and high image quality simultaneously. This slide illustrates the training process. Using clinical data, they exclude images with suboptimal acquisition conditions. For ground truth, they use high-quality images reconstructed with model-based iterative reconstruction (MBIR) under controlled factory conditions. For input, they use lower quality clinical images with additional simulated noise. Noise augmentation enables the deep learning model to better identify noise components and achieve reconstruction approaching the ground truth quality. We input intermediate images of captured scans into DCNN and output high-quality images proceed by DCNN as final images. This entire process occurs with one click. These graphs show the physical characteristic measured with a water phantom. AICE suppresses both high frequency and low frequency noise most effectively and achieve fine granularity. Higher MPF values indicate improved spatial resolution, and DLR enhances resolution. The figure in the low right demonstrates that with AICE, fine granularity facilitates identification of small structure. Comparison of FBP, IR, and DLR images. By implementing deep learning reconstruction, we can achieve superior image quality using the same dots. From here, I talk about the peak, precise IQ index. So, super high resolution image reconstruction technique using a deep learning. This shows the preparation of training data. They acquire super high resolution data. They create ground truth using MBIR from images acquired with super high resolution. After generating normal resolution from super high resolution through simulation, they created noisy images at various simulated dose levels as input images. In super high resolution DLR network training, they use 0.5 mm high noise normal resolution images created by simulation as input data, and 0.25 mm low noise SHR images as ground truth. They employ UNet architecture and performed 3D convolution. By introducing residual learning, they achieve stable and effective training, even in deep layer. With wide coverage detector CT systems that lack a high definition detector, by reconstructing images acquired with 0.5 mm slice thickness using peak, you can obtain images approaching high resolution over a wide anatomical range with a single rotation. We measured resolution characteristics using a cat phantom. This demonstrates that peaks resolution characteristics are superior. Peak demonstrated better low frequency noise reduction capability than AICE. NRCT with SRDLR provides noise reduction and enhanced resolution compared to NR with FBP, and stenosis and intent are more clearly visualized. However, note that there remains a substantial difference compared to SHRCT with MBIR. Peak's ground truth is 0.25 millimeter, but the original acquisition is 0.5 millimeter. So this represents appearance high image quality enhanced. The actual slice thickness has not changed. The ground truth is a critical factor that determines the upper limits of reconstruction image quality. The XR finding so GX finding I. We input frontal chest X-ray images, detect candidate regions, and output processing results. Detected regions are circled. This system detects nodules, masses, and consolidations. Sensitivity exceeds 80% with specificity at 88%. This paper describes the clinical utility of the system. About two-thirds of the regions missed without AI were found when using AI. For AI training data, they use images containing findings that multiple radiologists agreed should be detected, as well as normal images that multiple radiologists confirmed contain no region. We clearly specify the intended use, quality requirement, and acquisition subject conditions. This is because detection performance degrades under conditions outside the training data distribution. Additionally, during clinical interpretation, physicians first interpret independently, then use AI analysis results to support diagnosis. By having physicians read first before referring to AI analysis, we mitigate AI bias and support human clinical judgment. Next is a positioning AI. So, in cases where technologists were consulted, repeat imaging occurs most frequently. Among X-ray repeat exposures, there are images like these that do not actually require reshooting. Additionally, left-right positioning errors and incorrect projection method counted for 90.9%. Positioning I is a function that applies deep learning to images captured on the imaging console to assess positioning quality and left-right orientation. In positioning assessment, region judged to be misaligned are highlighted yellow and displayed as shown in these images. When actually acquiring a lateral knee view, positioning assessment and misalignment magnitude are displayed instantly like this. So if the criteria are unclear, the radiological technologists and the physician from the clinical department will discuss it together. This system aids objective assessment to repeat imaging decisions, so we can expect improvement in decision consistency across all staff levels. So with positioning eye, we notice the error after image acquisition. With this system, there is protocol consistency verification before exposure. So that is an extend tube with a optical camera. Okay. So AI analyzes the factor positioning. We take a photo with an optical image camera. AI analyzes the anatomical characteristics from the photo. In this example, it determines this is the left hand. It compares this with the anatomical region of the protocol selected before X-ray exposure. And if there is a mismatch, a warning is displayed on this screen. Therefore, by detecting errors before irradiation, we can prevent unnecessary radiation exposure. So this is an automatic extraction in non-contrast CT images. Yes. So this is same. I think that this quality is very good, but some in the area is done. So if you want to the more clear, so we have to use the contrast media. So as shown on the slide, deep learning analysis diverse. When implementing these technologies, note that there are differences in automatic segmentation accuracy and supported anatomical regions, and analysis depending on the vendor. Total segment data is a deep learning model that anatomically segments multiple organs in CT images simultaneously with high accuracy. It is trained of diverse clinical data, and both the model and data set are publicly available. You can add it as a plug-in to 3D Slicer, that is a free soft, and use it immediately. If you are interested, please try using this. In this way, they can provide interpretation support tailored to clinical purpose. I believe it is important to remain aware of bias in training data. In countries like Japan, where emergency medical systems are well established, and there are many ultra early stage regions, the detection performance of model training with data from other countries may decrease. Here is a subarachnoid hemorrhage. You can see. Okay. Next. In recent years, there has been a trend toward utilizing multimodal medical data spanning from medical images to electronic medical records as input. Research is being conducted to develop foundation models that can automatically generate radiology reports, support, support our advanced diagnostic assistance, streamline workflows, and discover novel insights from data. This is called MedSum. It's a foundation model for image segmentation that can instantly segment any region of any image according to user instruction. It can process pathology images, CT, MRI, and more. When the user delineates a ROI, segmentation is displayed automatically. This is also publicly available. You can use this one. So let me summarize the three main points I explained in today's lecture. I discussed why we need to learn about AI. I explained the AI's rapid advancement and important considerations regarding bias. Next was CNN, which is widely employed in medical imaging. Finally, we covered applications in actual medical devices utilizing AI. We, as radiological technologists, believe it is crucial to serve as a bridge to ensure the safety and effectiveness of AI technology through evaluation, implementation, operation, and quality control of AI tools. Let's work together with dedication. Thank you for your attention. Shin, come on,
Thank you very much, Mr. Shohei Mito. You have explained the concepts of AI from the basics very well. And the session is open for any questions from the audience side. Any questions from the audience side? Okay, I have a question to you. You explained about the bias, data bias, method bias, and cognitive bias. So, so can you say how this cognitive bias can be tackled? Yeah, how can it be tackled? Because data bias, it will be definite because the developers are feeding the system from different parts of the world. Because an AI model trained in European countries may be different when it works to an Asian country. An AI model developed in Asian country will perform differently in an American country. But how it can be tackled in a cognitive biased?
So cognitive bias is for developers have the bias and the doctor have the bias. So I think that we have to confirm the vendor. So where these data captured in the other countries. So that is a very important. So, but that is, I think, limited.
Okay.
Yeah.
Okay. Any more questions from you? Okay, thank you very much, Mr. Shoimido, for your excellent presentation, because you covered the basics very well. Okay, thank you very much.
The next presentation, I would like to introduce Mr. Hoàng Thị Liên with the title of 3D mammography using the healthcare system at University Medical Smart Hospital. Welcome, Mrs. Hoàng Thị Liên.
Xin chào quý ban chủ tọa đoàn, ban tổ chức, ban giám đốc bệnh viện cùng toàn thể anh chị em đồng nghiệp đang tham dự buổi truyền hình trực tiếp cũng như là thực tế. Em là Hoàng Thị Liên cùng đồng nghiệp Nguyễn Văn Rạng đang công tác tại Bệnh viện Đại học Isrrt-Rt-Rtt. Xin được hân hạnh chia sẻ về kỹ thuật chụp nhũ ảnh 3D trên hệ thống Hetia. Bài của chúng em thì gồm có 3 phần. Phần đầu tiên là phần tổng quan, phần thứ hai là phần kỹ thuật và thứ ba là so sánh nhũ ảnh 2D, 3D và kinh nghiệm thực tế. Trước tiên thì chúng ta bắt đầu về phần tổng quan. Theo số liệu Global vào năm 2022 thì ung thư vú đứng thứ 2 về tỷ lệ mắc trên toàn cầu với hơn 2 triệu ca mắc mới. Riêng ở Việt Nam thì ung thư vú đang đứng thứ nhất ở cả hai giới với hơn 24.000 ca mắc mới. Điều này cho thấy là tầm soát và chẩn đoán sớm là vô cùng cần thiết. Vậy hiện nay chúng ta có những phương pháp nào để chẩn đoán ung thư vú? Đó là siêu âm, MRI và chụp nhũ ảnh. Trong bài này thì tôi tập trung vào kỹ thuật chụp nhũ ảnh, đặc biệt là nhũ ảnh 3D. Phần thứ hai thì em xin trình bày về kỹ thuật chụp nhũ ảnh 3D từ chuẩn bị bệnh nhân đến nguyên lý hoạt động của Hetia. Đầu tiên là bước chuẩn bị bệnh nhân. Đối với bệnh nhân thì cần cởi bỏ trang sức, áo lót và mặc áo choàng của bệnh viện. Giải thích cho bệnh nhân về quá trình ép vú có thể gây khó chịu và thời điểm tốt nhất để chụp là 5 đến 7 ngày sau khi hết kinh. Điều này thì giúp giảm đau cho quá trình chụp và cũng cho hình ảnh chính xác và chống chỉ định đối với những bệnh nhân phục có thai. Nhũ ảnh thì được khuyến cáo cho phụ nữ trên 40 tuổi, định kỳ 1 năm hoặc 2 năm một lần. Ngoài ra những người có nguy cơ cao như tiền sử gia đình mắc ung thư vú và những triệu chứng bất thường cũng cần được chụp. Với nam giới cũng có chỉ định chụp trong một số trường hợp đặc biệt như là khối u ngực, tiết dịch bất thường ở nồng vú, thay đổi màu da và tiền sử gia đình cũng mắc ung thư vú và vú to bất thường với nữ, hóa tuyến vú kéo dài. Theo dõi điều trị ung thư vú và đánh giá trước và sau khi sinh thiết. Tiếp theo là kỹ thuật ép vú. Thì đây là yếu tố quan trọng để có hình ảnh chất lượng. Và một câu hỏi đặt ra là tại sao phải ép vú? Việc ép vú thì để làm giảm liều tia và giảm chồng chéo mô và tăng độ rõ nét. Mặc dù có thể gây khó chịu nhưng mà lợi ích mang lại thì vô cùng quan trọng. Phần tiếp theo thì em xin trình bày về nguyên lý hoạt động của chụp nhũ ảnh. Và có thể sử dụng phương pháp bước và chụp như ở hình A và chụp liên tục như ở hình B thì hình ảnh sẽ thu nhận được từ các góc khác nhau giống như ở hình C và hình D. Đối với thông số kỹ thuật của Hetia thì sẽ có góc quét là 15 độ và 42 độ tùy vào chế độ được chọn. Với độ dày lát cắt là 0,5 đến 0,75 tùy vào từng mô vú. Và hiện nay ở viện thì đang sử dụng góc quét là high resolution là tổng góc quét 42 độ. Điều này cho phép quan sát tổn thương ở nhiều góc độ. Và sau đây là bảng so sánh về liều chiếu xạ trung bình của mô vú, một yếu tố quan trọng về an toàn cho bệnh nhân. Liều chiếu xạ của ACR đặt ra là giới hạn liều tia 3,0 mg trên độ dày vú chuẩn là 4,2 cm. Đối với EUIF thì là tiêu chuẩn đặt ra là 2,5 mg cho tấm phantom dày 45 mm. Riêng ở HCA thì có liều chiếu xạ trung bình là 2,15 mg, thấp hơn cả ACR và EUIF thì nghĩa là an toàn về liều xạ. Sau đây thì em xin trình bày về các tư thế chụp cơ bản. Có hai tư thế chụp cơ bản. Đầu tiên là tư thế thẳng trên dưới. Đối với tư thế này thì bệnh nhân đứng đối diện với máy, chỉnh bàn ép phù hợp với chiều cao của bệnh nhân và thực hiện kỹ thuật ép, và sau đó là phát tia với tổng góc quét sẽ là 40 độ, 42 độ và bước góc là 2,8 độ trên một hình. Số lượng hình là 15 hình. Đối với những bệnh nhân nam có ít mô vú thì chúng ta đến thử kéo nhẹ cái phần mô vú ở quanh cuồng vú để tối đa hóa lượng mô cần chụp. Và ở những bệnh nhân có máy tạo nhịp tim hoặc ống thông tĩnh mạch cửa thì tốt nhất nên tối đa hóa lượng mô vú cần chụp mà không ảnh hưởng đến cái thiết bị ở bên trong ngực. Sau đây là một số hình ảnh được thực hiện tại viện ở trên tư thế CC. Và tiếp theo chúng ta sẽ đến với tư thế check trong ngoài hay còn gọi là MLO view. Thì đây là tư thế được giúp để chúng ta quan sát tối đa lượng mô vú trong một lần chụp. Thì với tư thế này thì cầu đầu đèn sẽ quay 40 đến 60 độ và tùy thể trạng của bệnh nhân thì thông thường sẽ là 45 độ. Và chỉnh tư thế bệnh nhân và sau đó thực hiện kỹ thuật ép với tổng góc quét của HCA là 42 độ. Sau đây là hình ảnh được chụp bằng kỹ thuật 3D ở tư thế nghiêng. Những hình này cho thấy rõ lợi thế của 3D trong việc quan sát và cấu trúc của mô vú. Slide tiếp theo thì em xin được trình bày về tiêu chuẩn để đánh giá chất lượng của hình ảnh. Đối với CC thì mình có thể lấy được càng nhiều mô vú càng tốt, và hai bên vú đối xứng, núm vú nằm ở giữa phim và ra ngoài phim, và có thể lấy được cơ ngực lớn. Điều này thì tránh bỏ sót những tổn thương sâu, và đường thẳng từ núm vú trên CC không lệch quá 1 cm so với MLO. Đối với tư thế check trong ngoài thì lấy được toàn bộ mô vú, cơ ngực lớn, ngang mức núm vú và nếp dưới vú rõ. Núm vú ra ngoài và đường thẳng từ núm vú thì so với tư thế thẳng là không vượt quá 1 cm. Và trong thực tế thì không phải lúc nào cũng chụp được ở tư thế chuẩn. Với những bệnh nhân có dị dạng lõm ngực, thiết bị cấy ghép hoặc là COS thì chúng ta có thể thực hiện bổ sung các tư thế check từ ngoài vào trong, đối lập với tư thế thông thường là chụp từ trong ra ngoài để quan sát vào vùng trong mà MLO không thể hiện rõ. Tiếp theo sẽ đến một tư thế bổ sung khác là tư thế lateral view. Với tư thế này thì xác định chính xác vị trí tổn thương và đánh giá vôi hóa, và là hướng được bổ sung sử dụng phổ biến nhất. Ở hướng này cùng được sử dụng để chứng minh sự vôi hóa dựa vào trọng lực như là sữa canxi, và được sử dụng khi tổn thương ở một hướng tiêu chuẩn mà không thấy ở hướng còn lại. Thì đối với tư thế này thì đầu đèn sẽ xoay 90 độ và cánh tay bên bệnh nhân, phần bên chụp của bệnh nhân thì dang 90 độ và đặt trên cassette như ở hình minh họa. Và thực hiện kỹ thuật chụp. Sau đây là một hình ảnh được chụp trên kỹ thuật lateral view. Chúng ta có thể quan sát được hết toàn bộ mô vú. Ngoài các tư thế bổ sung thì trong một số trường hợp cần thiết, cần khảo sát chi tiết vùng nghi ngờ thì chúng ta có thể sử dụng kỹ thuật chụp khu trú spot composition để tập trung vào vùng tổn thương. Đối với chụp khu trú thì đây là kỹ thuật đơn giản, và kỹ thuật này yêu cầu đo đạc chính xác vị trí tổn thương và ít nhất ở khoảng cách. Đầu tiên là đo từ độ sâu từ núm vú cho tới mức tổn thương, và thứ hai là đo ra trong hoặc ra ngoài từ đường núm vú tới tổn thương, và thứ ba là đo từ tổn thương tới da. Sau đó đánh dấu vị trí và sử dụng bộ ép có kích thước nhỏ để ép từ từ xuống. Sau khi tìm hiểu về cách thực hiện kỹ thuật chụp khu trú thì sau đây là hình ảnh minh họa thực tế. Hình này cho thấy là tổn thương trên vùng mô vú dày khi áp dụng kỹ thuật spot composition. Cuối cùng, đối với những bệnh nhân có túi đột ngực thì chúng ta sử dụng kỹ thuật implant displacement để di chuyển túi độn về phía sau, giúp chụp rõ mô vú ở phía trước, và đây là bước quan trọng để đánh giá cả mô vú và hình thái của tình trạng của túi độn. Có thể kết hợp thêm siêu âm và chụp MRI để tăng độ chính xác. Và sau đây là hình ảnh thực tế khi chụp ở tư thế thường và tư thế sử dụng kỹ thuật implant displacement. Tiếp theo phần 3 là phần so sánh và kinh nghiệm thực tế. Chúng ta có thể thấy so với 2D thì 3D mammography có độ phân giải cao hơn, giảm chồng lấp mô vú và tăng khả năng phát hiện ung thư xâm lấn, đặc biệt là ở mô vú dày. Tuy nhiên, thời gian sẽ chụp lâu hơn và liều chiếu xạ sẽ cao hơn một chút. Từ bảng so sánh thì có thể thấy 3D mammography có ưu điểm. Và slide tiếp theo thì em sẽ nhấn mạnh về điểm nổi bật của 3D so với 2D. Ưu điểm của 3D so với 2D thì 3D giúp giảm âm tính giả, giảm dương tính giả và phát hiện vi vôi hóa và đánh giá bờ tổn thương rõ hơn. Theo như ví dụ được minh họa ở phía trên thì chúng ta có thể thấy là trên hình 2D thì tổn thương chỉ thấy phần tăng đậm độ nhẹ. Tăng đậm độ nhẹ, còn trên hình 3D thì thấy rõ bờ tua gai tỏa ra, thì đây là dấu hiệu của ác tính và cho thấy khả năng phát hiện sớm và chính xác hơn của 3D. Đây, để chứng minh cho những cái lợi ích này thì chúng ta sẽ xem một số ca bệnh thực tế được thực hiện tại viện. Đối với ca bệnh nhân này thì bệnh nhân nữ 52 tuổi và được chụp nhũ ảnh tại viện vào ngày 10 tháng 9 năm 2025 và mã y tế là 25143183 và quan sát trên hình 2D thì chúng ta có thấy là sự co kéo của núm vú vào trong và thấy rõ cái tổn thương và vôi hóa mạch máu. Tuy nhiên khi quan sát ở trên hình 3D được tái tạo thì cho thấy các lát cắt thấy rõ bờ tua gai và tổn thương, phát hiện vi vôi hóa bên trong. Và những dấu hiệu này cho thấy dấu hiệu này thì quan trọng của ác tính. Và tiếp theo đây là một ca bệnh khác cho thấy khả năng phát hiện vi vôi hóa và đánh giá bờ tổn thương bằng kỹ thuật 3D. Thì đối với những bệnh nhân nữ chụp vào ngày 29 tháng 11 năm 2024 thì bệnh nhân này có kết quả trên siêu âm là nhân Isrrt-Rt-Rtt và ở vú phải thì là có nang. Nhưng quan sát trên 3D thì chúng ta thấy là ở vú phải thì có 2 vùng vi vôi hóa thô không đồng dạng ở vị trí 1/4 trong. Ở vú trái thì có nốt tăng đậm độ nhẹ và hình thái không đều, bờ không xác định và có gai và vi vôi hóa vô định hình. Điều này cho thấy 3D giúp phát hiện vi vôi hóa và đánh giá bờ tổn thương, hỗ trợ phân loại chính xác hơn so với siêu âm đơn thuần. Và qua 2 ví dụ trên cho thấy chụp nhũ ảnh 3D thì cung cấp hình ảnh rõ nét, giúp bác sĩ phát hiện và đánh giá tổn thương một cách hiệu quả, đặc biệt là ở mô vú dày. Bài của em đến đây là hết. Em xin chân thành cảm ơn.
Cảm ơn báo cáo viên. Sau đây thì xin mời các vị xem có câu hỏi gì đề cập cho bạn báo cáo viên. Vâng, cho tôi xin phép được hỏi một câu ạ. Ở bệnh viện bạn thì chụp cái X-quang tuyến vú 3D này thì có sử dụng tiêm chất tương phản không ạ?
Dạ, em xin trả lời câu hỏi của thầy. Thầy hiện tại ở bệnh viện thì chưa triển khai cái tiêm chất tương phản vào trong chụp nhũ ảnh ạ. Hiện tại bây giờ thì đang sử dụng cái kỹ thuật chụp là 3D thông thường với lại là những cái kỹ thuật bổ sung để giúp bác sĩ đánh giá một cách chính xác hơn.
Mình thấy rằng là nếu như mà chúng ta kết hợp cảm ơn bạn, mình kết hợp giữa cái chụp 3D ấy, này sau đó thì chúng ta có thể tiêm thuốc tương phản mà giống như CT ấy, chúng ta chụp lặp lại như thế một lần nữa thôi, vì nó có thể là nó tăng cái liều tia lên nhưng mà sẽ giảm được cái chi phí cho bệnh nhân rồi giảm những cái thời gian cho bệnh nhân phải đi chụp thêm cái cụm từ. Đấy. Thì cái giá trị của cái tiêm chất tương phản ấy thì nó có cái hay nữa là ở chỗ gì? Là nó giúp cho chúng ta phân biệt được ra cái khối u đấy ngấm thuốc như thế nào, mạch máu ra làm sao. Tại vì bản chất của các khối u thì bao giờ cũng có dầu mạch máu. Thì nó ngấm như thế nào thì cái đấy nó tốt hơn. Thì tại vì trong thực tế ra bây giờ là mình đang có các cái kỹ thuật mới ấy, thì Bộ Y tế họ đã phê duyệt rồi, là được phép dùng tương phản trong chụp hình vú 3D. Do vậy thì chúng ta cũng nên triển khai để áp dụng cái này để ứng cho cái chẩn đoán tốt hơn. Rồi, xin cảm ơn bạn.
Em xin cảm ơn thầy.
Yeah, thank you, thank you. We got just discussed about Vietnamese. We asked this hospital we have which this 3D mammography technique with you intravenous contrast agent. So this hospital is not just, but I would like to kind of ask you, international speaker, can anyone sharing about the mammography technique help you to intravenous contrast agent? Do you have in your country, India, with 3D mammography, you intravenous IV contrast? No, I'm not sure. So how about Taiwan?
Yeah, I think in Taiwan, only few hospitals with the mammography using the contrast medium. Not so popular, but some hospitals they use this. Yeah.
Yes, thank you. Because in Vietnam we have a pre-approval at health minister, so we can use IV contrast to detect more different diagnosis. Certainly, for doctor can use the 3D with IV. How can do the different more about diagnosis with IV or not or something like that.
But what is the use of IV? Because using the mammography itself will be able to delineate the lesion. Then why an IV contrast is recommended for a mammography?
Yes, because in Vietnam we have a new MRIs. We have is in more expensive than the 3D. Yes, yeah. So so if you can use the 3D, then it is more than patient can have for the patient can use less money for the MRI with the IV contrast. And I heard about Korean and Japan. How about you? And is you the this in the IV contract in your country is not? Oh no, yeah, yes, yeah, good. All place. Oh yeah, yeah, yes, good. For the same in Korea. So yes, thank you everyone. Thank you. So we are finished this session, and now for lunch time, welcome on the speaker and on the participant to go out and let to have canteen the place and with the but in lunch. Thank you everyone. Now we start with the pre-session this afternoon. And let's introduce the chairman, with Ms. Paul Nguyễn Thị An from University Medical and Pharmacy Hospital at Ho Chi Minh City. Mr. Phan Hoa Phương, Medical Imaging Department, University of Medicine and Pharmacy at Ho Chi Minh City. And Professor Jung Won Han, President of Korean Radiological Technologies Association. So please, Chairman, do quickly.
So we will start in these sessions in the afternoons is Professor Chi Fin Lo from Department of Biomedical Imaging and Radiological Science, National Yan Min Chao Chung University, Taipei, Taiwan, with the topic Radiomic and Deep Learning AI application in lung cancer diagnostic and prognosis.
Okay, so thank you so much. I know it's super long name, right? Okay, I mean the title, and even my department's name is super long, right? Anyway, just make everything simple. I'm going to talk about what can we do using AI in lung cancer. Okay, so lung cancer is one of the, I have to say, tough disease. Many people get killed because of the lung cancer, but now we can actually use AI with imaging to, I want to say cure, but to help doctors and patients to deal with the lung cancer anyway. And I have to say, I know this is lecture, and I know most of you, you are students, so I'm not going to do the presentation. I will teach you something, share something with you, and I anticipate that you will interact with me. So let us try it, okay? I mean, you have to do something with me, okay? Okay, so let's look at this one. We have already heard a lot of things about AI, right? So I would say AI right now, especially the medical imaging AI right now, I would personally cut it into two stages. Okay, you can see the very first stage right here. I would say AI can help us do so-called lesion detection and diagnosis. Basically, look at the picture. AI can help us find out where is the disease, where is the lesion, and also help us to identify whether the lesion is the good one or bad one. We will say benign or malignant, okay? Good or bad one anyway. So of course, when we are talking about lung disease, it can simply be a small lesion like a benign nodule. Nodule means small lesion less than 3 centimeter in diameter and weight. But of course, it can be a dangerous one. It can be a real lung cancer, even it is small. So the question would be, you can see the aim, the goal, the reason why we use AI for lung cancer. Because first of all, we want to reduce the effort or the work for the physicians or even for the technologists anyway. But of course, we also want to reduce the misdiagnosis rate. So that means the chance we miss the disease, right? That is something we want to do. But now, interaction. Now, a quick question for you. If you are the patient, yeah, look at me. If you are the patient, now the doctor says you have to pay additional money to get use of this AI, okay? So I'm not sure how much it would be really much for you. So let's say maybe 100 US dollars. You have the idea how much is it? 100 US dollars. If you agree to pay by yourself, not covered by the insurance, pay by yourself, 100 USD dollars, then you can get this kind of the AI to do the diagnosis for you. Will you pay for it? Okay, think about that. 30 seconds. You have to pay it by yourself, like 100 US dollars. Okay, 100 US dollars. Yes, just one. Yeah, you go to the hospital, you receive the low dose CT. Now you have the question raised by the doctors, 100 US dollars. Then you can get additional AI application to check whether there is a lesion that I may miss, that the doctors may miss anyway. But again, we all know the full responsibility is on doctors, right? If there is a so-called misdiagnosis, the doctors need to take the responsibility anyway. Okay, so now I want to see your hands. If you think you are willing to pay for this $100 for this AI application, raise your hand. One. Let me try. Yeah, just one. Two. Okay. Now suppose I think the remaining of you will say no, right? If you don't want to pay for this $100, raise your hand. Let me see. Okay, I will come to the ones who doesn't raise your hand. I will ask you why. Okay, so pick one. Yes or no? Let me give you one more chance. Yes, raise your hand. Only one hand and two hands, right? Okay. If you say no, raise your hand. You don't want to pay this $100. No. How about you, Nito? Will you pay? Well, okay. However, you are rich, so it is not a good one anyway. I mean, the students, will you really want to pay for this one? That is a big question because, again, the ugly truth is we know the doctors eventually, work without AI, doctors will take care of the diagnosis, right? Even it is time consuming, doctors need to spend time on it, right? Okay, so I would say now let's think about the next stage. The next stage, I'm calling it as the outcome prediction. So think about that. If, unfortunately, if a patient really gets the lung cancer, what is the question you want to ask to the doctor? If you are the patient, you get the lung cancer. I hope that is not true. But if the patient really got the lung cancer, what would be the question the patient want to ask? Normally, two questions. The very first question would be, do I have effective treatment? I mean, can this disease be treated, right? The second question would be, because lung cancer is fatal, it is super malignant. So the next question would be, how long? Yes. How long? How long should I book my ticket to, travel all over the world? My final chance, anyway. Okay, so this question cannot be answered by human doctors. I have to say, doctors will always show you the answer in average, okay? In average, that means based on the group study, maybe 1 year or maybe 15 months, in average, you can survive. If you get the regular treatment, maybe that is the number. But if you force the doctor, you ask him, I want the precise number to myself. I don't want you to give me the average number. Do you really have the precise treatment for me? The right treatment, not for everyone, but to me? Can that be the question, right? So I would say no doctors will answer you the question because it takes risk. If the doctor say, okay, you look like just 3 months, okay, but you survive more than 1 year, the doctor will get sued. Again, in a reverse way, if the doctor say at least 1 year, but you or your relatives anyway die within 3 months, you may sue the doctor again, right? So that is a risk. It is so hard to make the personal prediction. But again, I would say because lung cancer is that malignant, it is fatal. So the people will really want to know, if I do have so many different kinds of way to treat the cancer, surgery, chemotherapy, radiotherapy, target therapy, immunotherapy, I have so many options, but any of them will cost a lot. I would say even in Taiwan, chemotherapy, target therapy cost a lot. And the ugly truth is the treatment will actually take like 1.5 years. The process takes like 1.5 years. Then afterward, you will know whether it works or not. So it's time consuming, it's super expensive, and you are not sure whether this is useful or not to you, okay? So I would say the second stage of AI, we want to foresee something. We want to see the future, okay? We want to get the right treatment, right decision, specifically for one patient. So that is called precision medicine, okay? So you can look at the M right here, right-hand side this way. You can see we really want to identify the suitable, the right treatment for the right patient. So maybe we can prolong. That means let the patient live a little bit longer. Maybe that is the best way, okay? So I would say we talked about so many different kinds of AI in clinical practice, right? But again, the ugly truth is there are still lots of hospitals saying no to AI products. They think it's too expensive. Maybe human doctors can take care of that. I don't really need to pay for that one. But you can see the right-hand side, I call it a new business model. If there is really an AI can tell you your future, just like the crystal ball, okay, like the magician crystal ball in way. You may want to pay for it. So the question would be, now you are the patient who unfortunately get the lung cancer. But now the question is the same. You can pay for 100 US dollars, but you can get your own personal prediction about outcome. Identify the right treatment. Don't need to wait for 1.5 years, just 100 US dollars. I'm looking like a sales anyway. Will you pay for these 100 US dollars? Okay, so now if the answer is yes, raise your hand. Okay, more, right? More. Don't be shy. Raise your hand. I want to call your name. Okay. Why long? No more. Yes, very good. Okay, so if the answer is still no, raise your hand. You are scratching your hairs. Okay, no. Okay, very good. So I would say at least the more people will say yes, because we all agree this is something that currently the human doctor may have the difficulty to achieve, right? So if AI can really help us to do something that we cannot do right now, that is the true value of the AI. Okay, so let me come back to the lung cancer. The reason I want to take the lung cancer as the example, because look at this timeline right here. Lung cancer is a progressive disease, progressive cancer, and it progresses so quickly. Just like 1 year, patient died, right? Look at this. In the very beginning, we are looking at the possibility to identify small lung nodule. Again, remember, nodule means small size lesion. If we can identify this kind of a small lesion and identify it as the lung cancer, normally it's just like a stage 1. We can easily remove it through the surgery. And the outcome is much better than stage 3 or stage 4 lung cancer, right? So the very first question would be the reason why we use low dose CT a lot right now, because we want to do the patient screening to identify the potential lung cancer. But again, you have to know the ugly truth right here. There is always ugly truth right here. Even we have low dose CT right now, even we can easily identify the small lung nodule. Only 10% of them is malignant. So that means we actually waste a lot of money. Maybe you can say that, but maybe no. At least we save a small portion of the patient anyway. So you can see the very first question raised right here for lung cancer would be, now we have low dose CT, we can easily identify or detect the small lung nodule. But the question would be whether this is benign one or malignant one. If this is a malignant one, I want to receive the surgery. I want to take care of this. I don't simply want to, receive the 1 year or annual follow-up, right? Doctors will say, no worry, it's small, so maybe come back to the hospital next year. We will check again. But if that is a lung cancer, we can we will deal with it right now, right? Okay, look at the second stage. If now, after diagnosis, we are so sure it is lung cancer, what is the next question we'd like to ask? Look at the title. Again, the treatment outcome prediction. Which treatment can bring the patient best outcome? If you are the patient, you will go for it. You don't want to waste time, because the ugly truth, again, you will hear a lot of the ugly truth right here. The ugly truth in clinical practice right now, it's more like try and error. You say, hey, that is unfair anyway. But that is true. Even you catch a cold, remember, you visit the clinics and the doctor will say, okay, you are coughing. Okay, you have the sore pain anyway, sore ache anyway. I will give you the drug, right? Just take it for 3 days. If the symptoms still right there, you will come back, visit the same doctor and say, it doesn't work. What will the doctor say? I will change the drug for you. Let's try different dose, try different drug, right? Try and error. Of course, the try is not randomly. We will based on certain kind of the clinical guideline, but the clinical guideline is for group, not for specific patient. So try and error is a necessary and a common process in clinical practice. But again, when you are dealing with the lung cancer, you don't have much time if you are the stage 3 or stage 4 patient, just like 1 year. You don't really have time to try and error. And again, the cost is super high. Okay, even in Taiwan, it can easily cost you like I would say $5 million US dollar. Sorry, 50,000 US dollars for the target therapy anyway. So remember, that is the cost. So now let's look at the final stage right here. Now, unfortunately, if the process go for the final one, that would be the stage 3 or stage 4 right here. Now we really need to worry about whether there will be so-called brain metastasis or metastasis to any part of the body anyway. So remember, the cancer originated from lung, but in the late stage, this cancer can propagate or metastase to different organ. Of course, the outcome for the brain metastasis is the worst one because that is the central nervous system, right? Okay, so we have the question. You can see, again, the ugly truth right here. Around 10 to 40% of the lung cancer patient, they will eventually have this kind of the brain metastasis. So can we predict which group of patients will have the brain metastasis? If that is positive, if that is true, we can let the patient receive aggressive treatment or even the preventive, brain radiation therapy anyway. That is something we can do. Okay, so you can see that is the reason why we pick lung cancer, because it's kind of the challenging across different time points. In each time point, we need AI. We need AI to think about a lot of things, right? Okay, so but again, you can see we can rely on so many different kinds imaging for lung screening, cancer screening. Can this microphone work better? No one cares. Okay, so look at this. In the very beginning, we use low dose CT. But when we really know it is a cancer, we use contrast enhanced CT. But finally, when we are really worried about the brain metastasis, we will use brain MRI to check it, right? So again, even for imaging technique, we use many different kinds of the imaging techniques to deal with the lung cancer. So I would say quantitative features or even the AI techniques, it can help us to optimize.
If you talk a lot, sorry.
Okay, low battery. Okay, that is my fault. Oh, not my fault. Okay, so so remember, it can help us to optimize. Optimize means find out the best solution for clinical practice, and also it may be able to improve patient overall survival. That will be the duration patient can survive after the diagnosis of the lung cancer, right? And of course, the management, treatment for the lung cancer anyway. Okay, so in case you don't really know the lung cancer, look at the picture right here. Lung cancer can come with different kind of the pathologies anyway, but just remember one simple number. Around 80% of them belongs to the non-small cell lung cancer. Only 10 to 20% belongs to the small cell lung cancer anyway. But right here, remember, I think this is the number from the US data set anyway. Lung cancer come with high mortality rate. It is so fatal that you can easily see, even you sum up the mortality rate for the second, third, and fourth cancer, you can see the number is still higher for lung cancer patient anyway. Okay, so, and also right now, the international guideline for treating non-small cell lung cancer depends on the stage. Okay, so of course, I think you all know the stage can be determined by the size of the tumor, whether it's involved the invasion to the lymph nodes or even it comes with the metastasis anyway, TLM system anyway. So remember, again, this is the guideline. I say we don't really randomly try the best solution. We follow the guideline, but still you can see there's still some, base that the doctors can change the strategy. So that causes a problem. Some doctors may choose solution A, but some doctors may choose solution B. We don't really know which one is the best choice. That is the reality. And again, it can involve like surgery, like adjuvant chemotherapy, concurrent chemotherapy with the radiation therapy, or even the immunotherapy. It is huge and it is complex. We need something some algorithm like AI to help us even provide a second opinion or guide us, so we may be able to save time, save money for lung cancer treatment. Anyway. So let me quickly just sum up what I say, the unmet need. What is the key problems we want to solve for the lung cancer treatment? So remember, first of all, treatment resistance, that means the failure of the treatment. It doesn't work. It always happens. And also, there is a very good phrase called tumor always come back. We don't like these words, but that is true. So that is called tumor recurrence. Even you treat it so hard, you put so much energy, money, and time, tumor still come back. So that is tumor recurrence anyway. So based on this kind of situation, we know personalized treatment strategy is highly required. Again, just like what I mentioned, we want to solve this issue, find out the best outcome for the patient, okay? So based on this idea, we need tools, and one of the tools is called radiomics. I would say radiomics itself is not AI. Don't think radiomics is AI is different thing. Radiomics, let me give you the most simple way to explain it. Let me just do a quick survey. How many of you already know what is radiomics? Raise your hand. I want to see your hand. You know what is radiomics? Miko? No? Okay, that is new. How about you? Do you know radiomics? Yes. Don't be shy, raise your hand anyway. Okay. Maybe most of you don't know what is radiomics. You can see the plain English right here. Image patterns. Image patterns. Okay, you still say, I don't know. Look at this one. Do you know the QR code system? We all use QR code system, right? But why QR code system works? Because when we know this QR code system just like a matrix, an array. But this matrix actually just like an image. This image encodes the information inside this matrix, right? Again, you can see the pattern, black, white, coding in a certain kind of the way or pattern, right? I want you to compare the QR code system with the image we have on the left-hand side. Yeah, whatever. You can see right here, this is the MRI image. If I somehow do something on this image, compare this one with the QR code system, it's very similar. The question would be, maybe there is so-called hidden information coding behind the image. It can be MRI, it can be CT, it can be ultrasound, right? So what is the coding information behind this? Can we dig it out? Can we find it out? And the most important question is, if we can dig it out, does this information actually correlated with patient outcome? Okay, so that is the question we want to ask. So remember, radiomics is actually a combined word from two important words, just like the song, radiology is our home, right? Okay, radiology and omics. I think you all know gene, you know genomics. Genomics means a huge number of the values to describe the genetic profiles. So the same thing, radiomics means a huge number of the values that we can describe the pattern on the radiological imaging. Okay, so that is so-called image pattern. Remember, quantitative features, just like what I say, we need quantitative features rather than human decision or human human description. Sometimes we look at this image. The normal way that the doctors will describe the image would say there is a suspicious lesion identified with significant contrast enhancement in the surrounding area with hypointensity inside. We can see this kind of the description, but the description is not quantitative. If we really want to use AI, we need a real number. We need quantitative data anyway. Okay, so of course, my lab, you can see in 2018, it's pretty early anyway, we published one paper in Clinical Cancer Research talking about this interface. We create this multi-model radiomics platform. We can calculate three-dimensional radiomics. So you can see one tumor, for example, this is a brain tumor anyway. You can easily extract like 500 to 3,000 features to describe, quantitatively describe this kind of the brain tumor anyway. Okay, so what can we do with this thing? Let me give you several examples, okay? Look at the very first one. Now you can see there are two data sets right here. For the left-hand side, you see CGH. That is the hospital Guiyuan is currently working in. That is the hospital in Taiwan, Pasay General Hospital. And so that means this data set represents Taiwanese data set, okay? Right-hand side, NLST data set, this is open or public data set anyway, downloaded from the US project anyway. So it is the data set representing the American population. So the question would be, I want to answer the very first question. Can we use AI to determine the malignancy of the lung nodule, especially small lung nodule? So what is the definition of small? The diameter is smaller than 1 centimeter or 10 millimeter. That is super small. If you say the diameter is smaller than 3 centimeter, this is pretty common. But now I'm talking about the diameter smaller than 10 millimeter, 1 centimeter. It will be super difficult to determine whether this is the malignant one or benign one. So we downloaded, you can see 600 patient data from Taiwanese data set and around 600 data from the US data set anyway. You can ignore all the other things, but just look at this one. Look at this part. You can see the portion of the benign lesion and the portion for the malignant lesion. Actually, they are different, right? You can see the rate. The rate for US data set, we have higher rate to be benign. But actually, you can see in Taiwanese data set, we have higher rate to be malignant one. Okay, so that is the difference. You can see significant difference. So this gives you a very important hint. Do not think I can directly use an AI developed in Western country into Asian country. Because in a very important basis right here, we are dealing with different, I cannot say disease, but different regions, okay? In Taiwanese, I believe it's also true in Asia dataset. We have higher malignant rate in Asia dataset, okay? So let me prove that. You can see not only the rate of the malignancy anyway, look at the image pattern. We all know we have so-called solid, partial solid, and also the GGO, ground glass opacity. That means it's just look like a blur imaging with, not too high, not too low imaging intensity. That is so-called ground glass opacity. You can see, again, look at the ratio of the malignancy right here. You can easily see very different right here, right? You can see, again, in Taiwanese data set, we have relatively high malignancy. You can look at the number, 49% of the partial solid is malignant. But look at the US data set, only 30%. Right? Look at the GGO, it's very significant. The GGO ratio, just like the reverse number right here. GGO in Taiwan, yes. Sorry? No. Nothing about model. This is the ground truth. I mean, we have the pathology data, so we know whether they are benign. So this is a ground truth. It's nothing about the AI, okay? So this is the basis about what is the malignancy in the different races right here, okay? So that is important. We are dealing with different races, so we may deal with the different lesions. Even we say they are small lung nodule, but they are different. That is a key we want to say. So let me just directly show you the result. Now we create the AI model. For this day, we created AI model anyway. But I try to show you something. I can use, for example, I use US dataset, open dataset. I create an AI model. I train the model to classify, to predict whether it is benign one or malignant one. Now the trick is, now I use this model in Taiwanese dataset. So what would happen? You can see model 2 right here, this is the result. 0.58 accuracy, 0.78 specificity. Don't believe any doctors that only give you the correctness like 60%. That is not good enough anyway. So the AI telling you, if you use this kind of AI, you will get a very poor result if you switch the data set. However, look at the gray bar right here. We use something called transfer learning. That means I try to fine tune, I try to teach this model to know a little bit more about the Taiwanese data set. Actually, I only fine tune the hyperparameters for final few layers, not whole model, just final few layers. Then you can see now it can really deal with the Taiwanese data set in a pretty good way. You may think about that. Why don't we simply put everything together? Pull Taiwanese and the US data set together to train a model. This is the result, the white bar right here. The result is pretty poor. Why? Because we do have huge variation. So it gets AI confused. So sometimes you say this is benign, but sometimes you say this is malignant. So I would say if you force the model to learn a data set that comes with high variation, I'm sorry, you will still get poor results. So that is the reason why we always control our data set. We want to use the same machine sense scanner. We control the parameters, similar TR, similar TE. However, the real world actually have so-called variation. So this is very good data to show you. You can see the wrong prediction will focus on wrong place, but a good prediction will focus on the region area. So this is a very study I want to share with you to highlight the data set issue. You need to remember that. Don't always think AI is that good. Data set can cause the issue. So you need to also have the basic idea, knowledge about the disease itself, not simply the computer science, okay? How about the second study right here? Now, again, this is data purely from the CGH data set anyway. But now we collect the data from two different branches, one from Taipei branch, another one from different area, so-called Xizhi district anyway. But now you can see, again, this is the data set here. But you can see right here, now we collect not only the basic demographic data, you can see we record the patient staging, okay? And we also record the treatment that we applied to the patients. So you can see surgery, chemotherapy, radiation therapy, target therapy. We have so many different things right here. But again, the question is, I want to know if the patient really goes through this regular or combined treatment, can the patient really get a good result? Or can we really predict the patient's outcome if we really applied all these kind of the guideline or suggested or regular treatment? Can we really foresee or predict the patient outcome, okay? So again, I want to skip the part for AI. We can use AI, and we actually use one of the model called DeepSurf. So that is a deep learning model that can be used to predict the survival, okay? And based on the search from the computer, we identify these 5 clinical features like the histology, clinical T, and clinical stage, and whether the patient get the surgery or not. These 5 features highly related to the patient outcome. The second thing is you see lots of words you don't recognize right here. You don't know. That is normal because these are the radiomics features. We use pretty confusing name to name the radiomics anyway. But remember, these just are the features that we can describe the tumor homogeneity. I'm not sure whether you know what is the homogeneity. That means how the tumor, I don't know, the uniformity of the tumor, whether it's just like a pure white, pure black, or you actually see different white or black distribution or hyper or hypo intensity distribution on the image anyway. So that is so-called texture, or that is so-called heterogeneity anyway. So remember, we can rely on these clinical for the left-hand side and radiomic feature for the right-hand side. We can use all of the feature, send them into this DeepSurf model, train it. We can try to get the good result anyway. So for this figure, don't really care about the number right here. Just look at different bar right here. The blue one, just like combined. We use all the information we have, like the clinical one and the radiomics one. You can see the blue one always outperform others, right? It is always superior or better than others. That means if we can combine clinical information with image information, it can allow AI to do a better prediction or better decision. Just remember that one. If you only rely on imaging one or clinical one, again, the result is not good enough anyway. Let me give you this example. Again, come back to my original question. Now you are a patient. You don't want to get the average number. You want to get what is the specific outcome for me, okay? Specific outcome for me. So can I have the prediction for that one? So look at the image right here. Now I give you 5 cases, 5 different patients. You can see for the upper row right here, you can see OS. Again, OS means overall survival. how long does this patient survive? 3 months, 12 months, 17 months, 34 months, and 68 months. You know, for the right-hand side, it is a better case, right? Patients survive longer. Look at the second row. These are the imaging. Okay, I labeled the lesion with the red RI right here. So again, you can see the size. It doesn't mean small size means better survival or good outcome. No, even small size can give you pretty poor outcome, right? Now look at the final row right here. What does that mean? This is so-called personalized survival curve. Again, I should add it one more thing called predicted. Okay, this is predicted by the AI. AI draw these personal survival curve for the patient. Look at the horizontal axis right here. That means time. The unit is months. And the vertical axis right here is the survival probability. So of course, when you see 1, that means 100% probability to be alive anyway. So you can see if the curve drops very quickly, rapidly, just like the left-hand side, what does that mean? That means the patient may just simply go through like a couple of months, but the probability, survival probability gets pretty low. So that means high risk. You can always see there is a dashed line right here. What is that? That is so-called reference curve that we created based on the population. So you can compare the personalized survival curve with this reference or average risk curve right here. If this is above, then this reference curve, that means maybe good outcome. But if it is below the reference curve, that means high risk. Okay, so remember, this is the way we can combine imaging, combine the clinical data, create this kind of the personalized survival curve. So if you are the patient right here, maybe just go for regular treatment. You can get a pretty good outcome. But if you are the patient right there, I would say go for aggressive one. So that is a timing you may need to think about. Maybe I should pay for immunotherapy. Maybe. Okay, think about that. But again, since I mentioned immunotherapy and you don't see the immunotherapy data for the CGH data set, now we open another study. Actually, we are using the data from the Taipei Veteran General Hospital data set. This data set actually includes the immunotherapy. So we just want to, fill the final puzzle. Can we predict the outcome for the immunotherapy anyway? So similarly, you can see this is a data set, different histology, different expression level of the PD-L1 because this is targeting for the immunotherapy anyway. You can see the drug, the immunotherapy drug we used for this patient group. These are 5 common drugs that we used in Taiwan to treat the lung cancer anyway. Right here, I just want to highlight one point. Not only the radiomics within the tumor, actually the vessels or the vasculature, that means the structure of the vessels related to lung cancer can also bring us important information, especially when we are talking about the immunotherapy. It's all about the administration of the immunotherapy drug. It will go through the vessel, and we can call it tumor-associated vessel. Okay, so we can also perform the imaging analysis to quantify the patterns of the vessels anyway. So look at this one. There are lots of steps right here, but you can see after we build up the vessel mask, locate the tumor location, we can actually identify the vessel structure pretty close to the tumor or tumor-associated vasculature anyway. We can use that one, create different radiomics. Look at the results right here. Okay, for the left-hand side, we only rely on the clinical features to identify so-called low risk or high risk. That means better or poor outcome anyway. You can see if you use clinical features right here, it's your cell phone. Okay, you can difference. What does that mean? If you use clinical features, you cannot differentiate good or poor outcome. If you combine the clinical data with so-called intratumoral features, that is the regular RI, we look at the patterns of the tumors. Now you can see the significance right here. You can actually differentiate good and poor outcome. But now if we add in 3 more so-called peritumoral or tumor-associated vascular, you can see we can even push this kind of the differentiation power a little bit more. So remember, this gives us the hint, not only the tumor phalon or intratumoral heterogeneity right here, the vessel-related pattern, like the torsion, like the curvature of the vessel, can also help us to predict the outcome for the immunotherapy. And then finally, some laboratory tests like the mean corpuscular volume or total protein level can also be benefit this kind of the prediction. So remember, now we are talking about radiomics not only within the tumor, but also pretty close to the tumor. The final issue, final study I want to share is about the brain metastasis prediction. Can we predict whether this lung cancer patient may have a high possibility, again, with the brain metastasis? Again, pretty similar idea. We also include the peritumoral or tumor-associated vessel. You can simply compare the gray bar with the black bar. Gray bar means we add in the vascular radiomics. So you can see we can improve all kinds of the index right here, just from maybe 4 or 3% to it can be as high as the maybe 51% anyway. So that means vascular radiomics can also contribute something to this kind of a prediction. Okay, so you can see the results right here. Again, we include the vascular right here. Compare these two cases: 1 month and 21 months for brain metastasis-free survival. That means how long will the patient have the brain metastasis? 21 months and 1 month. You can see these two patients for red bar and blue bar, they have pretty different numbers for these values. So again, these image values can help us predict the patient outcomes in different stages of the lung cancer. In the very beginning, malignancy prediction. Second thing, treatment outcome, personalized survival curve. Final one, predict whether the patient will have the brain metastasis or not, okay? So to make the conclusion, remember this is a big picture, but actually, if we are dealing with MRI or CT, it can be multiparametric MRI or different kind of CT, low-dose CT, contrasting CT, or regular CT, whatever. You can use so-called radiomics to extract the tumor volume, tumor heterogeneity, or even intensity distribution, whatever. With the AI, again, it can be conventional machine learning or deep learning. It can help us deal with several different things right here. It can be just like the histology prediction, or it can be the future event prediction, just like what I showed to you, okay? This is the final 2 slides. I just want to say one more thing. Today, you heard so many lectures talking about the benefit from AI. But I want to send a warning to all of you. This is a paper published last year. You can see in 2024, March, right here. This is the paper published by the Harvard group. You can see the title right here. This is a very difficult title. I don't think many of you can understand this. Look at the left-hand side. Okay, this is an easy title for you because this is study delivered by Harvard Medical School. In the same time, when the paper published online, in the same time, the group also published this kind of the news. You can see the title. Does AI help or hurt? Okay, this is very 2 different verbs, right? Help means benefit. Hurt means it make everything worse anyway. Human radiologist performance. You can see what is the result. It depends on the doctor. It's very tricky. You don't answer the question, right? Why they say this? Why this paper? You can see the paper is published in Nature Medicine. It's a very high impact factor journal, but why they give this kind of a conclusion? Look at the data. The data for the horizontal part right here, that means improvement. When you allow the doctor using the AI, will the diagnosis become better or worse? If the diagnosis is better, you will see the improvement for the positive value. If you see the diagnosis become worse, you will see the improvement become the negative value. Look at all the cases right here, 140 diagnoses right here. You see the distribution just like a normal distribution with the average located at 0. So that means no benefit, okay? In average, there's no benefit. But you may still ask the question, there are still a group of doctors actually gain something from the AI, right? And again, a group of doctors actually hurted by the AI. So you want to find out, is there any factors that cause this difference right here? So look at these 3 figures below right here. You can see years of the experience. Maybe this is a problem of the doctors. They don't really have sufficient years of the experience, right? But look at this. they cut the 6 years as the threshold, the cutoff point. Less than 6 years and longer than 6 years, you see no significant difference. That means the benefit from the AI is similar, no significant difference. The second question, because they are using the AI system created by the Stanford, that is you can see the chest expert system. That's a pretty famous one and approved by the US FDA that is allowed to do the clinical diagnosis, right? But again, because that is focused on the thoracic disease. So whether the doctors come with a specialty in thoracic radiology, you can see again, no and yes, no significant difference, right? The final one, whether the doctors use the AI before or not, still no significance. So they give the conclusion, they cannot really explain why there's any factor, why there's no any factors can answer the question. So they give the answer, there is complex nature of AI-human interaction. We don't know whether the AI can really benefit the clinical practice anyway. But they actually give a very important conclusion. We really need to spend some time and energy to study the interaction. And then maybe in the future, we need to tailor. That means customize this kind of AI for a specific group of the doctors. Not all the doctors can use the same AI system. That is a big question. So I raised this the very first question. Different races can give you different performance of the AI, right? AI can be applied for different questions, depends on the question anyway. But finally, I send out a warning message. Don't always believe AI. Even the Stanford, the Harvard give you the conclusion. Sorry, sometimes it just doesn't help. So find out the potential AI-human interaction is the future key. Okay, just like the relevant publication from my works. So I want to thank, of course, Gui Yuan from the CGH, also the team from the TPGH, and also my team in NYCU, the National Yang Ming Jiao Tong University. So thanks for your listening. Any question?
Yeah. Thank you for the good lecture. Detection of lung cancer is very important. Yeah. In Taiwan, is low-dose chest CT applied as the primary test for lung cancer? In Korea, chest X-ray are taken at the National Health Insurance corporations every year. In Korea, some hospitals already have chest X-ray readings. Of course, the final confirmation is done by doctors. What about in Taiwan? And using deep learning technology, company called DK in Korea is working on applying the technology of equipment that detects lung and heart and aortic vessel and bone. There's each other abnormality with the chest X-ray. Does anyone have any? Oh, no. Okay.
Okay, so I think we have several questions right here. Let me answer the very first one. It's currently low-dose CT routinely used in Taiwan for just like the lung screening. I would say
every year.
No, it actually comes with a condition. Yeah. Now I think it's about 40 or 45, and if you do have the family history about the lung cancer, you can receive this kind of the examination earlier. But it's like biannual, or maybe annual for a certain kind of group, 2 years, right? Per 2 years. So it's more like the biannual examinations for this one. I think it's just like the recent 2 or 3 years, our government include this kind of the lung cancer screening into it should be 4 or 5 cancers, 4 or 5 common cancers in Plan 5, right? So it's the final one that we included in this kind of the regular national exam. So that is the first question. And the second question would be, when we are talking about the AI usage for lung cancer detection, or I would say if we are talking about the health examination, normally it's more like the lung nodule detection anyway. So I would say lung nodule detection is pretty common. Even in Taiwan, we do have several, I would say several different models of the AI that can be used or deployed into different hospitals to do the automatic lung nodule detection. But again, the question is always the same. We can easily detect even more than one. It can be multiple lung nodules within one subject's or on one subject's image anyway. But again, that is common. That is, again, FDA approved or Taiwan FDA approved products. We do have so many kind of things like that. But again, the question would be, now we know there is a lung nodule, but what is the next step? Okay, normally I would say in Taiwan, the clinical consensus would be if the size is larger than 1 centimeter, don't care about it, let's just go for surgery, okay? Of course, go for the video surgery, that would be easier, create a tiny small one, but again, that would be the case when you have the nodule larger than 1 centimeter. But I would say because now low density is pretty common in Taiwan, it's very easy to access this one. Even myself, even I'm not that old, I don't match the criteria for the government, I can still pay for it by myself. Actually, I did that in this May anyway. Okay, so this is super common. But the question would be when you identify a small lung nodule smaller than 1 centimeter in diameter, what is the next step? So again, that is the reason why we created it. But again, I totally agree with you. We do have so many AI systems that can not only detect the lung lesion, we do have something for brain, for heart, even for Guiyuan's hospital anyway. She also have something to calculate the diameter of the aorta anyway. So we do have so many kinds of AI. But again, come back to the original question. Does this AI system really solve the issue or problems that we actually face routinely in a clinical practice? And that is really valuable for both doctors and the patients. That is the question we want to answer. So again, I'm a bit different compared to all of you because I'm the professor working in the university. So not only the clinical practice, I'm thinking about the future. I'm thinking about what is a real problem or issues we need to pay attention to or put the energy inside. That is the question I'm looking at. Thank you for your question.
Thank you for your presentation. I think I really love the way you control the state. Very interesting. I have one question about around the slide 11 or 12. One research. We all know the data set is very important. Yeah, it's around this one. So have you checked this in these results the guidelines for the treatment? The guideline for the treatment from two different data sets. Have they used the same guideline for the treatment? And do you think the treatment guideline they use different will affect on the final results of the research?
If you are talking about this study, actually, these are two hospitals in Taiwan. Actually, belongs to the same healthcare system, the Kasei General Hospital health system anyway. So actually, we follow pretty similar guideline anyway. But of course, we all know doctors can have their own will. Some doctors will say, even there is a guideline, I want to try something, it is allowed. Even for radiotherapy, you know, some doctor will go for dose escalation, but some doctors will use the conventional dosage anyway. So I would say, of course, there is some individual difference caused by the doctors and of course the situations of the patients. But again, what we can do right here, you can see we only provide more like the binary data, like yes, we surgery or not, but we don't really record what is the method for the surgery. Right? Even for radiation therapy, we don't really report the dosage or the coverage. We only report yes or no. So I would say, yes, there's definitely room to improve the study, but in Taiwan, we definitely follow the international guideline for the lung cancer treatment, just like what I mentioned in the very early slides anyway. But again, the result can still be very different. Even you are dealing with the patients in the same stage, like stage 3, the outcome can still be very different. So that is something we need to think about. Thank you for your question. No more question. Thank you. Yes, my bad. It's your turn.
Thank you, Professor Lu.
No question, just
yes.
comment, right?
Okay, no. Only explain for Vietnamese know about you. First, yeah, you are rich man. You are well, man, too well, man. Các bạn ở đây và các bạn đang online, tôi sẽ nói bằng tiếng Anh. Nhưng đây là cơ hội không dễ dịp các bạn tìm được một người thầy giỏi như thế này, vừa trẻ mà giáo sư giỏi. Thế hệ các bạn sẽ được nghe cái radionomic, tức là những cái thuật toán nghiên cứu sâu một hình ảnh và đi theo dõi và chẩn đoán luôn sâu trong đó. Thế hệ các bạn sẽ được bắt đầu bằng người Đài Loan và người Nhật, người Mỹ họ đi trước. Cho nên đây là những cái thế hệ các bạn sẽ bắt đầu được nghe chữ radionomic như thế này. Ok, và tôi sẽ nói bằng tiếng Anh, tại vì ngoài ra còn các bạn trên thế giới nữa, và đề nghị cái tổ dịch phòng khác cố gắng dịch những gì tôi nói với ra tiếng Việt. Ok, Professor Lưu, the second time I know you, the first time you remember you talk about in radionomic in Asia CBD. Yes, but I cannot answer you in Asia CBD 2 months or 3 months ago, and now you are here again. I'm thinking, Professor, I'm thinking I invite you. Next year have a radiotherapy conference. I invite many oncology doctor. For example, this morning, the Professor Tung An from the Chai Hospital, he very well. I think in your presentation, how you share for in oncology doctor understand radiomics, very important, very. And the second question for you, you remember when you die, the early diagnosis for screening the low dose, okay? And now, how you say with everybody, AI impact in treatment with early diagnosis for oncology doctor understand. I believe radiology in future very important. And now me, I think that many doctor oncology also, they want to know how they impact AI, impact diagnosis, treatment, early treatment for cancer patient, lung cancer first. Okay, okay. Uh, Very good opportunity for my young member. Mr. You are professor.
Thank you.
Very well, professor. Very well.
Let me quickly provide my response. I don't want to delay Nick's wonderful speaker anyway. But I would say the crosstalk between radiologists or even radiological technologists with oncologists is super important. Radiomics, just like one of the way we can explain the image pattern to the oncologist. Because we all know AI, but again, some of the doctors from different departments, they don't believe AI because they cannot explain it, they don't see it, they don't understand why you say this is malignant one.
Of course.
So radiomics provide this kind of opportunity if we can use it well and we can use the right assay to prove it. I would say in my collaborated hospital, that would be the Federal General Hospitals, they are more than happy to use radiomics with AI to help them. If they can identify potential patient, actually it will increase their income, right? Okay, early cancer, come to my department. Now they can earn another money, but they can help more patients. That is the better way to say so. So I would say we are offering an opportunity to identify right patient, not the patient sending to the surgery room and say, oh, sorry, this is benign. That wastes so much resources and their time. So I would say, yes, radiomics and AI open a new possibility, opportunity, and a door for both of us. We can benefit with this. And the most important thing is patients will now believe doctors, the hospital can earn the money, everyone will be happy, right? Okay, thank you.
Okay, now I have one different, if difficult.
No, let's welcome.
Radiologist explain with oncology doctor. How? Why? You diagnosis. You are between explain for oncology doctor. Understand have AI. Radiologist, okay, everything. And now in radiologist explain with in oncology doctor. No, I don't believe it. I don't believe AI now. No, I don't
Let
believe.
me give you this one word, bridging.
Yeah.
Remember that word for all the first year student right here. I know most of you are first year student. Bridging. Don't think you are simply like a radiological technologist. I come with the same background with you. I'm the radiological technologist in Taiwan. But my mission is to be the bridging role. You know, I bridge doctors and the computer science. I bridge doctors from different departments. Maybe oncologists doesn't believe radiologists, but they will believe me if I show the data to them. I do have the skills to do that, right? So that is a role for because there's conflict between doctors from the department, right? But technologists right here, we help all the doctors in this house. We have that is the truth.
Okay. Let's invite you talk with in oncology doctor, not radiologist. Okay. Một cơ hội quá tốt cho các bạn nha, một kỷ nguyên mới nha. Cảm ơn nha. Thank you, Professor Lưu. Thank you, Chairman.
Next, we will continue the first conference with the topic of Mr. Mahas Barameswaran about the topic breaking barriers in MR imaging with AI integration. Please welcome.
Thank you, Chair, for the introduction. So after a wonderful talk about radiomics, such a confusing talk, he explained it very well. I never heard such an explanation, like explaining a radiomics in lung cancer detection. Hats off. Okay. Now it's my pleasure to share some insights about the most emerging techniques in the present era, that is artificial intelligence in MRI. So my topic is breaking barriers in MR imaging with AI integration. So here in this topic, I would like to cover the topic in such a way to discuss about the introduction of AI, something about machine learning and deep learning, artificial intelligence in MRI, some applications, current tools, and challenges and limitations. So what is artificial intelligence? So from the definition itself, from the name itself, it is clear that artificial means made by humans, but not natural. Intelligence, ability to learn, understand, and solve the problems. So the definition we can give, it is ability of a machine to mimic human thinking, like Google Maps. You ask a question, you ask a direction to the Google Maps. The Google Maps will give you the answer. Siri, Alexa, these are all the examples of artificial intelligence or AI. So what are the types of artificial intelligence? My previous speaker has explained all those things, but still, weak AI means it cannot perform beyond its capabilities. So we are in weak AI era. The future AI are strong AI and super AI. Strong AI means intelligence that are similar to that of humans. Suppose a robot is there in your home and you're asking a robot to bring a cup of coffee. So that is strong AI. There is a movie in India called The Robot. Its regional language is Yendran. So actually in that movie, it's an example of strong AI. In that movie, that robot is having emotions and feelings. Finally, he fell in love with a girl, and he's trying to impress the girl with helping her in cooking, helping her in exams, helping in preparing notes and all. Finally, the robot is making problems with her original lover, and a similar. Its name is a robot. You can search in YouTube. The foreign translation is also there. If you have a chance, you just watch it. Okay. The next is a super AI, means systems that surpass human intelligence. This above the human intelligence that are called super AI, but it's dangerous to us as well. Now, if you take the timeline of artificial intelligence, AI starts from the way back from 1940s. The idea of AI start from 1940s. In 1970s, small-scale toy projects in robots have been developed. And you can see in 2010, so 2000, the idea of IBM Watson has been developed. And you might heard about the IBM Watson beats the human Jeopardy player. Okay, so by 2000, you can see the storage and computation power of AI has gradually been increasing as such. And in 2018, Sophia, a humanoid robot, was offered citizenship of Saudi Arabia. So these are all the progress of artificial intelligence. So when you say about artificial intelligence, we should comment about two things. One is machine learning. What is machine learning? Machine learning means a subset of AI. For example, if you're showing a child a picture of a cat, and you're telling this is a cat, you are showing a picture of a dog and telling this is a dog, because you are teaching them with an example. That is called a labeling. That is a type of machine learning. Means you are showing something and teaching the child. That is machine learning. And another one is a deep learning. It's a subset of machine learning. Okay, see, I am moving my right hand. So that time, a particular area in my brain is activating. I'm moving my leg. Particular area in my brain, a motor area has been activating. I am speaking from here. My broadcast area is activating. If people are listening me, means your vernix area is been activating. These are all language areas in your brain. So if for each function, a particular area is responsible for that. So that is called deep learning. For each area, a particular neural network is there. Means in MRI, for noisy images, one particular area is there or neural network is there. One for anatomy, again, another neural network is there. So that is called deep learning. So machine learning means something you teach the machine or teach the system. But deep learning means something that controls the particular area or controls the neural network. So that is the difference. So how deep learning helps in MRI? First one, it removes noise and improve the image quality. It detects abnormalities, measure volumes of lesion, and helps a radiologist to interpret the scan faster. This is the role of deep learning. And you have seen this slide before itself. When you take artificial intelligence, it's a technique which enables machine to mimic human behavior. The machine learning and deep learning are inbuilt of artificial intelligence. And if you say artificial intelligence, it can be divided into machine learning, natural language processing, expert systems, vision, speech, planning, and robotics. So machine learning is concerned with radiology. So machine learning is again divided to deep learning. What is deep learning? I have explained it before. Then next is supervised learning. What is supervised learning? Like I said before, that you are teaching a child. Okay, this is a cat, this is a dog. You're showing a picture and teach them this is an apple, this is a mango, this is an orange. So that is supervised learning because a supervision here, supervision there. Teacher is teaching a student. That is called supervised learning. Then unsupervised learning means suppose a mother is teaching her child, showing the pictures that this is an aeroplane, this is a cat. So after some time or after days after, the child will be able to know which one is aeroplane, which one is orange, which one is apple. If we mix the picture together, he will study from himself, isn't it? Because he knows what all things he learned it before. Now it is easy for him to detect which is this, which is this, which is this. That is called supervised learning. Okay. Sorry, that is called unsupervised learning. So deep learning, supervised learning means a teacher is there to teach, and unsupervised learning is a child or the system itself will learn something. That is called unsupervised learning. Then a natural language processing. Natural language processing means the system or computer will learn from human language. Like what in Google Maps, you will ask Google Maps, you will ask chat box, no? Chat bot, you will ask something, the Google will like reply you, or the Alexa will reply you. That is an example of natural language processing. Then expert systems is there. Some systems or some AI models will take decisions. Then vision, like Facebook or in the mobile, if you show your face, it will automatically open. This is an example of vision. Then speech, like for messages and WhatsApp messages, you can directly speak to the mobile. It will convert to text. That's called speech text and text to speech. And it also deal with planning, and robotics. Now, let's say I'm switching to my topic, MRI. So MRI has the advanced MR imaging modality, which has got the advanced lack of radiation. It has got excellent soft tissue detail. Then it can acquire image in any plane, but it has got certain disadvantages as well. It has got long scan time, high cost, sensitivity to motion, prone to artifacts. As it has got a long scan time, there may be peripheral nerve stimulation, then increased specific absorption rate, SIR deposition. So these are all some of the drawbacks of MRI. So let's see how artificial intelligence can address this long scan time, sensitivity to motion, and prone to artifacts. We'll see one by one. So major applications of AI in MR include accelerated acquisition, means how fast we can speed up, or how can we speed up the MR acquisition. Then second one, image quality and motion robustness. How AI can increase the image quality and motion robustness. And third one, how AI can reduce artifacts. And fourth one, lesion detection and interpretation. Out of the four, these three, the first one, second one, and third one, are related to a technologist and the programming. And the last one is for a radiologist, lesion detection and interpretation. And some of the application of AI are in pipeline. See, what are they? One is acquisition, reconstruction, post-processing, interpretation, and workflow integration are in pipeline. They are not yet fulfilled. Okay, completely not fulfilled completely. They are still in pipeline. So what are the data characteristics relevant to AI? You know, MR is a multi-contrast. A jungle of sequences are there, like T1, T2, then Spinnaco, gradient, so many sequences are there, different vendor names. But basically, MRI has two types of sequence. What are they? Spinnaco and gradient. All other are the variations of these two sequences. But when we teach or when we instruct an AI, we should specify all those things. Means we should give all the names of the sequence, because in one vendor, for example, G's name is different, Siemens name will be different. For G, one sequence is called Sys3D or Fiesta. In Siemens, it is called Sys3D. So different vendor name will be there. So a AI model which is trained in one system, if we test in another system, it won't work. So that AI model should be trained with all the machines. It should be trained with Siemens machine. It should be trained with the GE machine. It should be trained with Philips. It should be trained with Canon. It should be trained with the Toshiba. So that is the problem with AI. That is, MR is a multi-contrast. It is a sequence rich. It is a high dimensional, means all 2D images, 3D images, 4D images, everything we have to fed into the AI models. Then motion, then heterogeneity in scanners. Heterogeneity in scanners, like different scanner types. Protocols. Protocols may be different. Protocols which are using in Taiwan may not be same as that be using in Philippines. That may not be same as in Japan. That may not be same in Sri Lanka. That may not be same in India. The protocol type will vary. So again, the AI have to be taught with all these parameters, all these sequences. So that is heterogeneity in scanners, protocols, and artifact profiles. Different types of profiles should be fed with. Then model generalization and domain shift handling, because AI trained in Asia, like my previous speaker had told, AI trained in Asia may not work well in Europe, or AI trained in Europe may not work well in America. Okay, so that geographical distribution or geographical stability should be there. Then also MR spectroscopy and quantitative MRI, they are imageless. MR spectroscopy and quantitative MRI have no image. They are imageless. They have this graphical values and numerical values, graphs and numerical values. So all these graphs and numerical values are also should be taught with AI, or also should be fed with AI. That is that is the job of a developer of that particular AI, to teach all these things to AI. That is, that are the data characteristics are relevant to AI. Then what are the core AI concepts for MRI? One is supervised learning. You know what is supervised learning? Like a teacher teaching a student. That is supervised learning. Then unsupervised or self-supervised learning. So that is something that teacher or that student will study from himself, or from the knowledge what he acquired. That is called the unsupervised learning. Then explainable AI. So you might have seen those who are working in MRI. So if you select something like a wrong TR or wrong TI, the machine will pop up a message that you have selected a wrong TR or a wrong TI. Try to change the exact TI. So that's called explainable AI. So when you get an explainable AI, there you will develop a trustworthiness with the machine or with that model, because you can rely on that machine. Yeah, this is correct. The machine, what the machine is telling is correct. So that is called explainable AI. So common AI models in MRI are CNNs, convolution neural networks. My friend from Japan explained about this convolution neural networks. Then UNets, transformers, and hybrid architectures are some of the common AI models which are used in MRI. Now, these are the steps what is happening in MRI. One is protocoling. Next one is positioning, planning, execution, sampling, reconstruction, pre-processing, analysis, and diagnosis. So selecting the best protocol or selecting the optimum protocol is very important while doing an MRI scan. Wrong protocol may not give adequate diagnosis. It will confuse a radiologist or confuse the AI. So selection of the best protocol or selection of good protocol is a must. So depending on the diagnosis, the AI models should select the correct protocol. So positioning, there is no need to position the patient like what you do manually. You just take the patient inside and just give the anatomical landmark. Like if you are doing a tumor protocol, you just give the anatomical landmark at anterior commissure or posterior commissure. The system will automatically plan itself. So that is it helps in positioning or planning. Then excitation. There is nothing to do with excitation in AI. Then sampling, of course, there is something to do, which will come in the next slide. So some of the AI-based planning methods are in Siemens, we call it as DOT, daily optimization throughput. That is the AI model, which is used in Siemens is DOT. Then G Healthcare, it's called AIRX, AIRX. In Canon, it's Auto Assist. So Siemens have one more model, it's called Deep Resolve. So these are some of the models which are used by several vendors for this protocoling and positioning. So how it helps in automatic planning? See, this is how we manually plan MR brain. Okay, so this is the anterior commissure and this is the posterior commissure. So we plan parallel to the anterior commissure and posterior commissure. That is what we manually do. But if AI is there to help, if there is an AI to help, you need not to plan as such. You just give the anatomical landmark, anterior commissure, posterior commissure, or ACPC. The system will automatically plan in such a way. Okay, for example, if you want to do an epilepsy case or an epilepsy protocol, no need to plan this. You can just mention the hippocampus. This is the hippocampus. You can just mention the anatomical landmark at hippocampus. The system will automatically plan perpendicular to hippocampus. So that is the advantage of AI. And it also helps in shimming, means improving the field in homogeneity, field uniqueness, because inside the MRI field, the magnetic field may not be unique. So actually the machine will do some pre-scans before the final scan to keep it homogeneous. So these AI models will help to improve your homogeneity, thereby reducing the artifacts. Then let's see what are the advantages of AI. It has got high speed, means higher acquisition, has higher signal to noise ratio, means strength of the MRI signal to noise. Okay, that is signal to noise ratio. It has got higher contrast to noise ratio, means difference in signal intensity between two tissues. See, you read this and you read this. There is a clarity difference is there. No, the background is a little bit held here. So you'll be find difficult to read both this one, but it is more easy because that is called the contrast noise ratio. Then images have higher spatial resolution. And spatial resolution means you can delineate or differentiate between two tissues. See, this is the internal capsule. This is the putamen. You can differentiate between these two tissues. That is called spatial resolution. So these all things are improved while using an AI model. And images can be acquired faster. So these are some of the advantages of AI in MRI. I repeat, first one can say this faster image acquisition. It reduces scan time. Second one, enhanced image quality. And third one, automated lesion detection. So automated lesion detection is a different one. All others I have included in this enhanced image quality. This increases spatial resolution, increased contrast noise ratio, artifact reduction, all will come under this enhanced image quality. First one is faster image acquisition. So let's talk about how it works for faster image acquisition or accelerated acquisition. For that, I have to say some basics about MRI. So this is a pulse sequence of MRI. It is a combination. What is MRI? It is a combination of RF pulses, signal, and period of recovery. When you apply RF pulse, you will get a signal. You will get one signal. Okay, like what you take an X-ray. When you take an X-ray, you are not giving a single photon. You are giving multiple photons. Isn't it? When you take an X-ray, just you are giving multiple photons. Similarly, when you do an MRI, you are giving multiple RF pulse. Then only you will get an image. So one RF pulse will give one signal. Similarly, several RF pulses are required to create one image. Okay. So one image is not the product of one signal. It is the product of several signals. And the distance between two RF pulses is called TR. And the distance between the first RF pulse and the first signal is called TE, time to repetition, and TE. So a patient is taken inside MRI. So what is this? Hydrogen protons. So hydrogen protons are spinning around its own axis. You apply an RF. What happens? The hydrogen protons have changed direction. So thereby a signal is produced. Okay. So when you apply an RF pulse, a signal is produced from the whole brain. But from which part of the brain this signal is coming? Is it from the right hand side? Or is it from the left hand side? Or is it from the anterior part of the body? Or is it from the posterior part of the body? Because the signal is coming from the whole brain, isn't it? For this, you are applying something called gradients. And these are called gradients. And this slice selection will give the location of the slice you plant. The frequency encoding gradient will give either it is from the anterior part or posterior part the signal is coming from. And the phase encoding will give you the details about whether the signal is coming from the right part of the body or left part of the body. Slice encoding, frequency encoding, and phase encoding. So this is how in MRI machine, the encoding gradients are placed. The first one is slice, second one is phase, and third one is frequency encoding, which gives the spatial localization of a human brain or human body. So why I explained this, I told before that when you apply one RF pulse, you will get one signal, or we call it as echo. A spin echo sequence always consists of two pulses. One is a 90-degree pulse followed by a 180-degree pulse. So this is a 190-degree and this is a 180-degree. So this two pulse combines the spin echo pulse. So the scan time in MRI machine or MRI is TR. So you know what is TR? The time between two RF pulse into number of phase encoding steps. Means how many times you apply the phase encoding gradient into next. Next means how many times the scan repeated. That's called next. So each time you are applying one RF, you will get one echo that is filled in something called a K space. So K space is an imaginary space where the data of MRI are being stored. That is called K space. So each time you apply a signal or RF, you will get a signal which will be filled in. Which will be filled like this, one by one, which will be filled like one by one. So scan time, it is a multiple value of TR into number of phase encoding steps into next. And how many times you have to repeat the phase encoding steps depends on the resolution of the image. For example, you know the resolution of your mobile, isn't it? Like 512 into 512. 1026 into 1025. In mobile, the image resolution is there. Similarly, if you take an MRI machine or MRI image also, there is a resolution. So this is the resolution, base resolution, 256 into 50%, means 50% of 256. So what is it? 128 into 256. That means the scan have to apply 128 times for the face encoding steps. So each time you apply a face encoding steps, it will fill the data. Again, one face encoding step, it will fill the next data. Again, filling one face encoding steps, it will fill the data. Likewise, 128 times the data have to be filled. Then you will get an image. So how we can reduce the time? See, this is the formula. So you can reduce the time by reducing the TR. But if you reduce the TR, the problem is the contrast is changed. This is a T2 weighted where you are used a TR value of 5000, but as per formula, you reduce the TR to 400, but the contrast has been changed. You see the ventricle is white there, the ventricle is black here. That means the contrast has been changed. So that is not possible. Then the next step is you can reduce the next. When you reduce the next, the image will be noisy. The image will become noisy, very noisy. That is also not acceptable. Then what is the other way? You reduce the face encoding steps. So how will you reduce the face encoding steps? You can reduce the face encoding steps by skipping the face encoding lines like this. So instead of 124, this time you filled 64 numbers. You skipped the one by in between one. So this is called undersampling. We call it as undersampling or skip k-space lines. So when you undersample the k-space lines, you will get an image like this. But is this acceptable? This is not acceptable. For this special reconstruction technique is there to get a final image and using something called Isrrt-Rtt, sense and grappa. Those who are working in MRI may be familiar with this. So these are some parallel imaging techniques. With this technique, you will get an image like this, but you can reduce the time. This is the conventional method of reducing time. Okay, conventional method. But using the AI model like UNet, see, you are taking the undersampled data, you fill it with something called zero padded data, then it go to folded image, and again you pass to UNet, the AI model, and finally you will get the UNet output, which is full of case space. This is full case space, this is partial case space. So with the help of a UNet, you are getting a much good resolution image with lesser time. That means if you do a conventional type of scanning with reduced with an undersample technique, suppose you take 2 minutes, this will be done within 1 minute. That is the advantage of using AI or this UNet profile. See, this is the regular acquisition. Whole case space is filled, normal acquisition. This one is conventional acceleration type. You are skipping one case space line. Okay. So you reduce the time, but you are reducing the SNR also well because you skip the scan time. This is something we are using in deep learning based technique or an AI based that it can reconstruct high quality image from fewer data points. You can see only few data points are being filled. So these models can predict the missing information. So that is the advantage of AI models. Then the second application is enhanced image quality. That means reducing noise, reducing motion artifact, increasing shimming homogeneity. That all comes in application of AI in MR acquisition. So how it is working? It helps in reducing artifact and motion correction. So a deep model sometimes can estimate and correct motion and case space inconsistencies. The benefits of this include fewer repeats and shorter effective sometimes. So you can see post-contrast motion images in the first row. You can see the motion images, but the same images with the AI correction, you can see how the image looks like. The clarity of the images are drastically changed in the second row. That is the other way of other application of artificial intelligence in MRI. Again, an arrhythmic heartbeat. See, in arrhythmia cases, we won't get a normal image, heart image like this. It will be full blurry. It will be artifact. But here you can see the AI-assisted software. We are getting a good resolution or a good SNR arrhythmic heartbeat, a high resolution images, and also a functional MRI with good resolution. So these are all examples of some AI-based images. and also artifacts due to field imperfections. B0 field B0 field inhomogeneity. B0 means the main magnetic field, that is called B0. Okay, magnet, that's called B0, main magnetic field. B1 is the RF field. You apply some RF field, that is called B1. So B0 and B1 inhomogeneities. So in MRI room, if you have seen, you might have noticed that it is actually protected with a Faraday cage. A copper shield is there. Okay, because no other radio frequency should be passed or enter inside the MRI room. That is called a Faraday cage. If you operate in a radio in near the MRI room, it won't work. The radio won't work because all these RF frequencies has been protected, or RF has been shielded with this Faraday cage. So that means the MRI machine should need high homogeneity, should be perfect. So sometimes the field, if you take some nail or some iron thing inside the MRI room, then the homogeneity will be gone. So that subtle inhomogeneity can distort your image. So this field inhomogeneities can be addressed by using AI models. Then chemical shift and metallic implants. Metallic implants can also produce artifacts. Then all these deep learning techniques, deep learning based AI models can leverage for B0 field homogeneity mainly in 3 ways: by supervised learning, self-supervised learning, and deep learning based image synthesis. See, this is an example of a diffusion EPA sequence. You can see the artifacts, distortion artifacts here, but the same image has been corrected with an AI model without an artifact. Similarly, again, one more diffusion image you can see with a distortion artifact, which has been corrected using an AI model. So these are some of the examples of images which has been corrected with AI algorithms. Then deep learning algorithms can improve image resolution as well. That means it can affect image quality. We'll see how. Some deep learning denoisers and super resolution models can improve the signal to noise ratio and effective resolution, which leads to fast scans. For imaging, resolution, SNR, time, they are dependent. So when we want a good resolution image, we need to compromise time. We should take more time, or we should acquire the images with more time. If we need a good SNR, for a good SNR, then time should be compromised. Good resolution, time should be compromised. If you are not taking care of time, then you will get what? You will get SNR will be low. You will get good SNR, good resolution. So all are interrelated. So these AI models or some AI models can allow us making improvement in spatial resolution by improving the signal. So you can see in this example, it's a high resolution, but noisy image, isn't it? The grainy images you can see. See, these are grainy, but this is a conventional type of image. But the same acquisition has been done with a deep learning or AI model with the same voxel size, 0.4 into 0.4 into 3 mm, to get somewhat corrected good image with a denoising filter. So same image acquired with a less time, you got a good high resolution, high SNR image. So that is another advantage of AI model. Next example, this is a T2 weighted image, Spinaco, acquired with a voxel size of 0.4 into 0.4 into 4 mm. The total acquisition time is 2 minutes 46 seconds. But here you reduce the voxel size. So when you reduce the voxel size, the SNR will be less. Normally the SNR will be less. But here you reduced the voxel size. You done with a deep resolve technique with an AI model. It was 72 times faster. Means total acquisition time is 46 seconds. But this time it was 2 minutes 46 seconds. Here it has reduced to 46 seconds. But the voxel size has been reduced, but still you get a clear, good signal to noise ratio, high resolution images. So that is an example of another AI model helping to improve the quality of the image. This is another example showing IAV, where you can see high resolution images. Again, a brachial plexus image done with an AI model. And how it helps in automatic reporting. This is not our part, it's a radiologist part, but still, let's see how it is affecting or altering, how it is changing the reporting schedule. So AI models like unit variants and transforms segment tissues, tumors, white matter lesions, and structure for quantification. And they collect data from the various sequences what we are doing and do the segmentation. Segmentation means AI models will they will segment some white matter together. They can segment gray matter together. Okay, from that, see, for example, see, you are going to a playground. So playground are a grassy, green color. Okay. So suppose some odd thing, or sometimes suppose a paper, a white paper is seen in the ground. It is very easy you to pick up, isn't it? You understand me? Are you following? Suppose you go to a playground, it is a greenish color, and somewhere a paper or a big paper is there in some corner. It is very easy you to identify because you have segmented that greeny thing is already segmented, means all area is green, and you picked something odd. That is called segmentation. Likewise, in brain, the gray matter, the white matter, everything is segmented separately, and then the lesion is picking up faster or quickly. So that is what called a segmentation of neuroanatomy. Then classification, various tumors like low-grade glioma, high-grade glioma. So like that, the tumors can be classified into different classification. That is another advantage. Then anomaly detections, because like supervised learning, you are teaching the AI model with some normal anatomy, like you are feeding the system with normal anatomy. So the system can predict when it sees or when it predict when it get a abnormal anatomy. It will easily pick up. No, suppose if you are showing, you are teaching a technologist about the normal brain images for a long time. For 6 months, you are teaching him a normal anatomy, and if he sees an abnormal anatomy, it is easy for him to pick up because by his experience he learns. Like that, the machine also, the system will also learn something from the supervised learning, and with the effect of unsupervised learning, that anomaly has been detected. Then it helps in breast MRA, triage detection and response with lesion detection classification, and even therapy response prediction, like was our professor explained in the previous session, that therapy response. So it can predict how, what about the therapy, how effectively the therapy can respond to that particular disease. Then it helps in spine MRA and degenerative disease, like it detects degeneration. No need for a radiologist to pick up all those things. If you put the images in the AI model, the AI model itself will pick up the details and pick up the herniations, stenosis patterns, everything. Then also quantitative MRI and parametric mapping. See, in MRI, all are not images like what we do in spectroscopy. We are giving graphical data. In perfusion, like CVV, cerebral blood volume, cerebral blood flow, that time we are using quantitative values, numerical values. So AI models can pick these numerical values or quantitative values very quickly and can predict the anomalies. Then spectroscopic image, like what I said before, it will predict a peak, a abnormal peak in the brain. Then what about data curation, labeling, and governance? For getting a good quality AI model, what should we do? Or what should the scientists do? High quality labels means the images what we are giving to the AI model should have high quality. Multi-site data, like if a data has been taken from a particular area alone, means for example, if it is developed by in a European country and if it is being tested in an Asian country, it may not work properly. So that is called a database, or like what sir explained that forenoon session, data. Then robust quality control, quality assurance and quality control are needed. Regular quality control, quality assurance should be required. Then synthetic data and augmentation. Sometimes the scientists who are developing this model may not get enough document or enough protocols to fit in it. So that is what they do models. That is called augmentation. They do 3D models or augmented model and will teach the system, will teach the AI model, okay, this is the disease, or this is the model what you have to do. That is okay, but it should be perfect. So an experienced team should be there when they develop an AI. Then again, governance include consent, privacy, and data lifecycle management per clinical standards, because for each country, the rules will be different. the because in some countries, that strict medical rules are there. So that time, that all things have to be considered. Then AI tools must be tested on external and prospective data sets to ensure they work across hospitals and scanners. So also all AI models should be tested that they should work in all hospitals or all scanners in a proper way or in a unique way. It should not sometimes in some area it will work well, in some area it is not working well, means it is also again it's a problem. Then let's see what are the challenges of AI adoption in healthcare. One is data quality. Like I said in my previous slides, that it needs a high quality data. Then patient information must be kept safe. None of the patient details should be exposed because it is their privacy. So patient details should not be revealed. Then ownership, who owns the medical data? Because when you if you trust an AI, there is a trustworthiness between the AI model and the user should be there, because these patient data or the patient data should not be transferred or should not be taken by the developer for their research. Then storage, images are very huge and storage is also a problem. Then knowledge, sometimes AI gives answers without explanation, like what in sometimes reporting, the AI will suggest that, okay, this is a lesion, this is a low-grade glioma. It won't give an explanation, means a lack of trustworthiness is there. How will the radiologist believe that this is a low-grade glioma or high-grade glioma? So what conclusion, how you end up in a conclusion to say that this is a particular glioma? So that explainable saliency should be there. Then sometimes AI will replace certain tasks in near future. Sometimes it can see nowadays also for the in some centers for the cardiac MRI and all, no, there is no need for a full-time MRI technologist. Even a CT technologist can do a cardiac scan. You just want to locate the left ventricle. When you locate the left ventricle, all planning will be done automatically. And even the protocol will be set up. If it's in a hypertrophic cardiomyopathy, you just type it as hypertrophic cardiomyopathy. No need to plan everything. Everything will be done by the system, and the system will do the scan. At the time of the contrast injection, the system will pop up, okay, you inject this contrast. So a technologist is not at all required when when a good AI feature is being applied. Then regulatory, it should meet regulatory standards, and cost also. Buying and maintaining is very costly. So as radiographers and radiation technologists, remember that attrition can be the biggest side effect of technological advancement. So all of you should continue to update yourself with relevant knowledge and be willing to learn the advances. So let automation run its own course. No need to make ourselves competition. So we are approaching 9 billion world population. So healthcare delivery is going to be the biggest challenges for governance across the world. Okay. So anyway, artificial intelligence will come in 100% today or tomorrow. So we should expect that. And radiology is going to be a key support specialty across the board. And always remember that AI will not replace medical professionals, at least for the foreseeable future. Okay, so many times the questions will be asked, will AI replace a technologist or will AI replace a doctor? So at least for the foreseeable future, it won't replace, but it will most certainly impact healthcare, and it will be mostly for the good. The human brain is a culmination of several billion years of evolution and nature's most complex design to date. So it will not be easy to replicate. Thank you. So any questions?
I'm just mentioned. It's important to make a noise-free image file, reducing the scan time. However, it is difficult to reduce making images through functional MRI or spectroscopy or each other sequence. But it would be nice if we could reduce the scan plane. For example, it, it would be nice if we could construct the coronal scan with sagittal plane and axial plane.
Of course, I agree. But the problem with most of the sequences in MRI. No, you see, when we do a functional MRI, we need a high quality 3D image because it have to be reconstructive, axial, coronal, sag. Even if we are not using AI, it will take at least 4 minutes to get at least a good resolution image. So these 4 minutes there is a chance for movement or motion. So in conventional method, one correction method is there called MOCO series, MOCO series. But if you use a AI supported sequence, you can reduce the scan time to 1 minute. Means the chance of motion is very less. Okay. The SNR will be more, but the chance of motion is very less. So thereby you can address this issue.
With the role of technologist, I take a lot of benefit from applying AI in my daily work. But there are still some debates about the accuracies of the AI is made compared with the traditional image. Can you share with us about your viewpoint about this issue?
Yes, of course, it is there because we cannot trust AI completely because we are in an era of weak AI. Okay, we are not in an era of strong AI. We cannot completely trust the AI. That is why we are looking for an explainable AI. Because if an error, the AI is picking an error, it should be explained in such a way why you are explaining like that. An explainable AI, a good AI model should be associated with an explainable AI. In certain things, when we select a protocol, sometimes wrong protocol can be selected. For example, if we enter the diagnosis as hippocampus lesion, the AI can take it as an epilepsy case, maybe it's a tumor. Okay, because we mentioned as a hippocampus lesion. So the epilepsy can be due to a hippocampus lesion or a tumor. But what we need is a tumor protocol. But the AI selected an epilepsy protocol. So that is why it is said that we should not trust AI completely. Okay, at least the near future. So tomorrow it will be completely AI dependent. But at the present stage, we cannot trust AI completely. Similarly, that is applicable for the radiologist as well, because they cannot rely 100% on AI because errors can happen.
I have a question. We see AI can change many steps in MRI examinations, like the position, the reprocessing, and the noise. So, how do you think about the futures for the radiology technicians grow in the futures?
The science is growing. Science is growing, like what Professor explained last talk. In the near future, see, every day new AI models are implementing. Even the fresh AI models, then long-term AI models, like this convolution neural networks and all, it is in the advanced stage. Presently, it is in the advanced stage, but it's very costly. The CNN, most of the vendors, if they are quoting a very high price, if we are asking for these convolutional network models, so that depends. Means so maybe like it's like a automobile manufacturing. No, see, day by day the technology and advancement is being happening. Similarly, in the near future also we can expect more AI models addressing all those things. See, the present condition is limited. In MRI application, it is limited only. It's mainly applicable for faster scans, in acceleration. Second one is image denoising. So only in limited areas presently AI is, we can trust is 100%. The rest of the all things are not 100% accurate.
Thank you. Yes, because our final speaker has some family matters and cannot attend, so this will be the last presentation of this conference. Thank you for your joining this conference. Thank you a lot. We have direct outside the intros.